Okay. It is visible?
Yes.
Hello?
Ma'am, please share the slides. Your screen is visible.
Just open it. It is not there.
अमन,
Ma'am,
आप
your
पहले जैसे गए थे वैसे जाइए, पहले जैसे गए थे ना वैसे ही
Okay.
जाइए अमन।
Okay. Now, ma'am.
अभी भी दिख नहीं रहा है। अमन, किसी की हेल्प ले लो, वहां पर कोई है क्या हेल्प करने के लिए?
अभी भी मैम अब दिख रहा है?
Ma'am, your screen is visible. Please open the PowerPoint presentation.
PowerPoint presentation is open actually. It is not moving.
अच्छा,
No, ma'am, your slides are not visible.
अमन पहले अनशेयर करो फिर शेयर करो।
Okay.
अनशेयर एंड देन शेयर।
I just stop sharing. Screen sharing. External window. Then, window sharing. No, it is not open.
Miss Amandeep, just click on the share button, and when you
Yes,
click
ma'am.
on the share button, screen share opens.
Yes,
Click on
ma'am.
that window and select entire screen instead of
Yes, ma'am.
window.
Okay.
Okay. If
Yes.
that doesn't work, click on presentation, PowerPoint presentation, because you have three options there, right? You have Chrome tab, you have Windows, and you have entire screen.
Yes, ma'am.
Three options, right? So try entire screen and then click on PowerPoint. Then we'll be able to see your PowerPoint, and just click on the start presentation mode in the PowerPoint.
Ma'am, when I click the entire window, then this window open. But I do not
No
able
problem.
to see my.
Now you just, no problem. Now you just click on your PowerPoint and we will be able to see the PowerPoint. Yeah, perfect. Now at the bottom of the PowerPoint, there
Yes,
is a start presentation. Just before the Zoom 70% that is written, there is an icon. Just click on that icon
ma'am,
and you
it's
will go to presentation mode.
Cup shape icon is there. Cup shape icon.
this one.
Yeah, perfect.
Yes.
Thank you so much.
Go ahead.
Okay.
Right.
Okay. So sources of contamination is human activities such as spillage, radioactive escape while dispensing a small amount from the bulk, adopting shortcut or violating the code of safety practices, not informing the co-workers or colleagues about any accidental spillage or contamination, inadequate handling facility in the laboratory, patient administered with radioactive radiopharmaceutical vomits in the room, patient personal belongings such as clothes, bed linens, utensils, emergency surgery of therapeutic patient, autopsy of therapeutic patient, or any kind of animal work. Can experimental work on animals can also cause contaminations. So how we can do contamination monitoring? So firstly, what is our objective during contamination monitoring is firstly to prevent the spread of contamination, to detect the failure of contaminant, draw attention to a deviation from standard operating procedures, to keep contamination level below the control standard, to provide useful information in planning the monitoring of individual or air contamination. So how we can do contamination monitoring of workplaces. Firstly, it's direct monitoring of workplaces. In this, the counting instrument or portable contamination monitor is directly placed over the area, and the total contamination will, with both fixed and loose contamination, will be measured. This technique is useful at such locations where sample by smear test is difficult. When monitoring is performed in an area with high background count, such as near the isotope generator, it is unreliable technique. So second is indirect monitoring. In this, smear sample are taken and then counted separately in low background area. This is a method that is better suitable for low energy beta emitter nuclides or loose or transferable contaminations. Poor reliability because the quality of reactivity transfer to the swab will depend upon the pressure applied, area swabbed, moisture content in the swab, and the technique used. It is not usable for the detection of spot of contaminations. Air contamination monitoring is usually filter paper with 99.9% collection efficiency are preferred. Filter paper impregnated with charcoal or grounded charcoal is used for iodine 131 contamination in the air. The cold paper strip used for H3 contamination in the air. So how we can do internal contamination monitoring. It also do with the two methods, direct method. In this, the gamma camera used without collimator or by monitoring of thyroid by thyroid uptake probe. The whole body counter can also be used for direct monitoring. And indirect monitoring, in this, nasal swab to determine respiratory intake of radioactive aerosols. Urine or feces sample are estimated for internal contamination. Alpha and beta emitters are detected through bioassay sampling. So how we can do decontamination? What is decontamination? It is a process used to reduce or remove radioactive contamination to reduce the risk of radiation exposure. What is the objective of decontamination? Firstly, the removal of contamination from occupied area, equipment, and personals is important to maintain an ionizing radiation dose as low as reasonably achieved. Decontamination also reduce background radiation levels, radioactive material inventory, and spread of contamination to uncontrolled area, equipment, and personals. Decontamination may be accomplished by cleaning or treating surface to reduce or remove the contamination. It may be also accomplished by filtering contaminated air or water, or by covering the contamination to shield or absorb the radiation. The process can also simply allow the adequate time for natural radioactive decay to decrease the radioactivity. So, what is the procedure for decontamination of small radioactive spillages? For small radioactive spills, use protective clothes or disposable gloves. Quickly blot the spill with the absorbent pad to keep it from spreading. A plastic bag for contaminated items, as well as some damp papers, towels must be available. Remove the pad from the spill. Wipe with towel from edges of the contamination area towards the center. Dry the area and perform the wipe test. Continue the cycle of cleaning and wipe test until the wipe samples indicate that spill is cleaned. Decontamination procedure for large radioactive spillages. For large radioactive spills, demark the affected area and notify all people in the area that a spillage has occurred. All people not involved in the spillage should leave the area immediately. People involved in the spill should be monitored for contamination when leaving the room. Prevent the spread of contamination by covering the spill with absorbent paper and restricting the access to the area. Survey to determine the extent of contamination. If clothing is contaminated, it should be removed and placed in the plastic bag labeled radioactivity. If the contamination is occurred by short-lived radionuclide, the physical decay of 8 to 10 half-life of radioactivity is preferred. After a period of time, the surface can be cleaned with moist swab or water. If this attempt is unsuccessful, detergents like soap solution, Telopol or EDTA can be used for loose contaminations. To remove contamination from glasswares, use soap solution or chromic acid. For metal surfaces, mild acid like 0.1 normal HCl or HNO3 can be used. Fixed contamination of surface can be removed by journal abrasions. If it emits high energy gamma radiation and has long half-life, the contaminated object may be treated as radioactive waste and disposed of permanently. All radioactive material should be placed into the plastic bag or other container to prevent recontaminating the area. So, decontamination procedures for body orifice. Orifice needs special attention because absorption of radioactive material through them is more rapid than those skin. Oral cavity, use toothpaste to brush your teeth. Frequently rinse the mouth with 3% citric acid. For pharyngeal region, use 3% H2O2 to gargle. Ingested radioactive material, use gastric laxatives. Nose, rinse with tap water or physiological saline. Eyes, rinse with steam of water or physiological saline directed from inner to outer cathis while avoiding contamination of the nasolacrimal glands. Ears can be rinsed externally with water. For auditory canal, use ear spray. So these days, various therapeutic agents is available, which it can be used for skin decontaminations, like for skin and hair, as we earlier discussed. A common soap solution or a detergent solution with a low acidity is recommended. Chelating agents like EDTA 10% solution for skin or hair, DTPA 1% aqueous solution with pH around 4 for washing, potassium permanganate 5% aqueous solution used when conventional washing is ineffective. Hydroxylamine or sodium hypersulfate 5% aqueous solution freshly prepared can be applied after potassium permanganate or Lugol. Then wash the contaminated area with water. Antiphlogistic topical ointment also available. It must be applied for fixed contamination, especially used for contamination of fingers. Isotonic saline solution for eyes. Isotonic 1.4 carbonate solution for removal uranium from the body. Lugol solution for iodine contamination. Acetic acid pH 4 to 5 or simply vinegar is used for decontamination of P32. So how we can minimize the risk of contamination? Firstly, access to controlled area must be limited. All staff who working in controlled area are issued a personal dosimeter which must be worn whenever they enter the controlled area. All operations involve unsealed sources should be carried out over a drip tray behind the L bench with the lead bricks. Radioactive vials must be kept within suitable lead shields. Unshielded vials of activity should only be handled with long handling tongs. Syringe containing radioactivity should be fitted with lead syringe shields whenever possible. The bench tops, which is used for manipulating of unsealed sources, should be covered with absorbent papers. Avoid unnecessary contact with all other objects present in control area. Gloves should be removed and disposed of in the radioactive waste bins as soon as work with radioactive substance is finished. Continuous contamination monitoring is important. To avoid skin contamination, wear a lab coat or other suitable clothes to prevent accidental contamination of normal clothes. When working with any unsealed sources like preparation of radiopharmaceutical, drawing up of dose, or administering the two injection, disposable gloves should be worn. Before eating or drinking and before leaving the laboratory, lab coat should be removed and hand must be washed. Only use disposable paper handkerchiefs. To avoid internal contamination of radionuclide, skin cuts or abrasives should be covered before working with unsealed sources. If there is chance of splashing, eye protection should be worn. Mouth pipettes must never be used. Always use a bulb pipettes or syringes to measure radioactive solution. In restricted area, no one should eat, drink, smoke, or apply any cosmetic. If a person or patient vomit or leak urine or other body fluid after the radiopharmaceutical administration, then the area must be considered as control. So wear a protective clothes, use valve shield, syringe shield, and the other shields like L bench, lead bricks, and instruction at every access point must be put it on, and decontamination kit must be present at every radioactive laboratories.
Ma'am, sorry to bother you.
Hello.
Ma'am, we're running behind on the schedule. Could you please?
Hanji ma'am, this is the last one. This is the last slide.
Yeah.
So decontamination kit, these are main components which decontamination kit must have, like protective clothes, shoe covers, plastic apron, face masks, soap solutions, detergents, soft nail brushes, long tongs, forceps, paper rolls, absorbent papers, barriers, ropes, etc. So whenever the contamination, any kind of radioactive contamination can occur, don't be panic, ask for the help. Thank you.
Thank you, Aman.
Thank you.
Thank you very much, ma'am. We now invite Dr. Sneha Shah for a talk on pediatric nuclear medicine. We request our chairperson to kindly introduce our speaker for the session.
Dr. Sneha Shah is a professor of nuclear medicine in Tata Memorial Hospital. She has around the experience of 2 decades in nuclear medicine, and she has been an integral part of breast DMG and also takes keen interest in pediatric oncology. She is going to deliver a talk on image gently pediatric nuclear medicine.
Can you hear me? Good morning, everybody. We're going to move a little away from whatever we've been doing in the lab to what you're doing into the machine and gamma camera room. So I'm going to talk to you about what is little different what we do when we are imaging children. So we all know they are the little ones whom all of us care, and we need to show a little more love and attention when we are scanning them. I'm going to cover these topics, why it is different, because and what is different in pediatric malignancies, the radiation burden associated with imaging, what we need to take care of, and what are the different protocols that we have, and some tips what we can encounter and do to make the imaging process a little more comfortable. Let's look at this very busy slide, and you can see that majority of the pediatric malignancies are solid tumors, and the other half are the blood uh, malignancies like leukemias, and rest account for the brain tumor. What is different in pediatric malignancies is that earlier, because they were children and there were not many medicines available, the outcomes, that is the survivors, were less than 50%. But over a period of time, with more and more research, treatment modalities have changed, and it's become multimodality where we have chemotherapy, radiation, as well as immunotherapies, and the survival has now jumped to about 80%, which means that of 100 child who's treated with cancer, 80 of them are likely to survive the cancer because most of them are curable disease. So what does this bring with it? There is something which is curable, but along with the curative intent, what happens is there are side effects of the treatment which are present. What are those? Second malignancies, cardiac toxicities, lung toxicity, infertility, and many more. And that is the reason when you treat a child, you need to be very judicious. Judicious in terms of not only treatment, but also in terms of investigations. Why investigations? Because we all know that investigations are something which might cause harm along with the drugs. Drugs you have to anyways give the child. You will have to then look at what investigations you can do and in such a manner so as to reduce the toxicity. The trends are changing. That is why when you're treating not only adults, but also in pediatrics, more so actually in pediatrics, we are giving them tailored treatment and we're trying to see what we can give and what we can avoid. So imaging is used in treatment, obviously when you're going to diagnose a treatment, but also as and when you're going to treat the child, you want to know whether what treatment you're giving is working. If not, you change the treatment. And so you have two types of imaging, all of us know, the radiological imaging as well as the metabolic imaging. What each one gives is, one tells you about the tumor size and the reduction, and the other tells you the metabolism of the tumor as well as the functioning of the organs which are associated with it. So that is why we use hybrid imaging. What does the hybrid name? All of us are aware, both anatomic as well as metabolic imaging. Imaging in pediatric oncology, like I said, is done at multiple stages, like staging, treatment, at completion, at surveillance, and at restaging. Surveillance is something which we can avoid, especially in pediatric, because we want to reduce the radiation burden. Most of the times we use CT and USGs, mostly USGs. If like I work with a pediatric group and I know that whenever I'm imaging a child, we try and see whatever information we can get with a sonography, we avoid a CT scan or a PET CT study. But where it is necessary and important, we do it. And because of the fear of radiation exposure, PET CT and its uses were very late as compared to the adults and in using. And why? Because obviously it's the radiation which is there. Let's come and look at the radiation burden which a human, whether an adult or a child, is exposed to when you do a PET CT study. And you can see that in this slide that there could be four different types. The mouse is not. There could be 4 different types of scans which you can acquire. One, an H1, where you will have a completely dedicated CT scan associated with a PET scan. Second, where you will have a low dose CT along with a contrast CT and a PET CT study. The H3, where you have a low dose protocol, and an H4, where you will have a low dose or a diagnostic CT associated with it, where the concentration or the MA values are different. On an average, an adult patient will get somewhere around 25 millisieverts of exposure. So what should be done? If you look at all these 4 parameters, can I use a pointer if you have? It's not working. It only, okay. Do you have a pointer? Okay, it's okay. So when you look at these parameters here on the U, what mentions is the exposure, the tube potential, and Q is what is the MAs which is available. In all these, the first four are the ones which show you that they are the low dose CT and the exposure is somewhere around.
नहीं आपने बोला ना कि हम बताएंगे सुबह.
Okay, thanks. Can I request people who are there to please mute themselves? You all are disturbing the speaker as well as
पेमेंट
the audience.
तो हाँ आपने कोटेशन दे दिया है तो आप ही को पता चलेगा कि सर ने पेमेंट
कोटेशन बाद में दीजिए, कोटेशन आप म्यूट करके दीजिए.
ठीक है देखते हैं अगर मुलाकात होगी तो आइडिया लग जाएगा. कैसे ठीक है.
Okay, I'm sorry for the disturbance from the audience. There are these three low dose CT scans which are done along with PET CT, and you can see that the radiation exposure is low in these three. The last four in this are the ones with a diagnostic CT scan. If you look at this, this is 14.1, which says is where your tube potential is 140 and your MA is 150. Keeping the same diagnostic CT, if I play around with the tube potential and the MA, the radiation reduces. So if you look at this, the third last slide, it goes down to 9.5. If I've just made a minimal change in my tube potential as well as the MA, right? So if we move around to know as to what exactly we want, if we want diagnostic information, we can have a high MA and a high tube potential. But if we are not needing that, then we may just go down to on the MA value to reduce our radiation. This is very useful, especially when you're looking at a patient for treatment response where CT information is not needed and only metabolic information is needed. We can reduce our MA. So the optimized call, depending on what is the indication, is very important. If you yourself don't know, please ask the doctors who are associated with you as to should I reduce the MA value for this patient? What is the indication? That's why I'm sure every hospital has its own chart or a history sheet which tells you why the scan is being done at the present time. Coming to these three protocols, which were the study which had been put forth by the group of Huang et al. From Japan, where he again looked at three different protocols of the CT scans, and he looked at what would the presence of noise level be and what would hence be the lifetime cancer incidence. And it says that if you look at doing a diagnostic CT and a PET scan, it would be 0.5 times more in the US population and 0.6 times more in the Hong Kong population as compared to the routine incidence of cancer in a normal variant. So coming to the term of image gently, we are always going to image gently for everybody, not only child, but for a child it's even more. So the term image wisely applies to you adults and image gently applies to the pediatric population. What should we do to reduce the radiation dose? We have two components in PET CT, the PET as well as the CT component. Both can be tweaked when you're looking at a pediatric patient. So this is what all of us are aware of, the pediatric calculations. And we must keep in mind that a child is not a small adult. You can't say if you're giving an adult, give 10 and give the child 5. It's not a miniature, he's not a dwarf, it's a child. So these are what the formulas which were available, the body mass, the BSA and the Webster's. However, studies have proven that the BSA and the Webster's is something which gives more radiation to a 1-year-old as compared to teenagers. And this is because it takes into account just that the size of the patient. And hence, there was this which came into picture, the US Radiopharmaceutical Committee, along with the Radiology and the Nuclear Medicine Society, came up with the actual consensus guidelines, which told you how much radiation would be exposed and how much should be given to a child. And this is what has been recommended as 3.7 to 5.2 millibecquerel per kg for a child for a whole body scan, as well as this is the dose for a brain study. Now, there's always going to be a European site as well as an American. So what should we use? There was something which had an ENM came up with a dose card. Right? You don't have one size fits all, and depending on what is the size of the patient, what is the age of the patient, what is the weight of the patient, you try to give the dose. And it's a little cumbersome, but I'll explain it to you in a minute. So you have the multiples of the baseline, and you had what are these classes of radioisotope you're going to use, A, B, and C. FDG falls into the B category, and how much dose you will administer will depend on the baseline activity, that is what is the weight of the child, and the class of the tracer that you're using, and that's multiple factor. So now let's look at that example. If I had to give a child FDG whose weight is 50 kgs, I will go and try and see where is my 50 kgs. The multiple is 10.71, and it's a B category fluoride 3D scan. 14 is the multiple factor. So 14 multiplied by 10.71, and this is the amount of dose I will be giving a patient. This is the ENM dose card. Now, everybody will say, I'm not going to be using this. It's a very tedious procedure. No, you need to have a little tedious thing because it's tackling children. Now, how do you harmonize what the American Society said and what the ENM said? And this is what they said, that let's try and keep a fixed amount of ENM dosage card to be used in their population, whereas the American guidelines said we will, keeping with that in mind, we will not give a child more than 26 millibecquerel, which falls into the range of the ENM dose card. So there was a compromise which was attained. But if you really want to be stiff, you can still continue to use the ENM card. Coming to the CT component of PET CT, we saw PET component because the radiation from the FDG component. Coming to the CT component, like I told you earlier, what determines the radiation dose is the X-ray beam, that is the kilovolt, and the X-ray intensity, that's the milliamperes. What I showed you from the previous radiation from the CT component. So image gently. What is another thing where clinical trials are actually done? Many centers identify a reference level. That's called the diagnostic reference level. They have phantom studies which are done when the machine has been installed into your department, and that machine identifies using phantoms, pediatric phantoms and adult phantoms, the reference level. That reference level gives you a valuation based on height or weight of the child, and this is what the kilovolts should be put for, and should be the tube current, and which should be the thickness and the pitch, and tells you exactly for that weight child what should be your DRL factor, and automatically you can put it onto your machine. So this all are the different variations which you can do when you want to image a child. The three things which I mentioned is the amount of dose of FDG, what you will use. I'm talking only of FDG because that's the commonest workforce of our department. Secondly, how much CT component you should calculate, or the ENM dose card, or use the DRL factor of your department machine. And what does all of us have high-end machines now where there are automatic CT protocols which the machine chooses based on the input of the height and weight of the child. What this automatic exposure does, it tries to adjust the radiation based not only on the length of the patient, but also on the 3D thickness. What it says is, if this child is lying down like this, we know that at specific areas, there are organs which are more radiosensitive as compared to the others. So at the sites where the penetration required is more, there the energy level is higher. Where the penetration level is not needed, the energy level goes down. So this is how a graph will look. At the same time, there would be a 3D acquisition taking place, and at levels where the attenuation is going to be more, that's where the your energy levels will be higher. At the places where the attenuation is less, the energy levels will be more. So both longitudinally as well as in the 3D format, there will be an energy exposure changes which will take place at the Z-axis and the XY axis both. So what it does is it takes an X-ray projection, which is your scout. All of us know what a scout is. Based on the scout, it will manage and identify how to put in your automatic. But there's always, nothing is black and white. There's always a gray zone. So depending on the automatic, there'll be a lot of noise. So you have to balance out the noise factor along with it. So this is how any machines, I've just given you what a GE machine would provide you, where you need to adjust your noise reference to your MA range and then see what whether you choose a manual or you choose an automatic control. So this is what they have given, provided that for a patient with a width of so much, this will be the noise if you keep this much, this many minimum MAs and maximum. So if you want a lower noise, you will have to have a lower MA. But if you want a higher MA, then this would be your noise index for this width patient. So you need to try to balance out what exactly is required. So these are the different machines which have, I won't go into details because I'm sure all of you will know more about this than I know. So coming back to the contribution of the CT, you try and identify if you only need the CT for attenuation, use a very low MA with a low voltage, use a high voltage where you want anatomic localization. But if you want a dedicated CECT, you might need both high MA and a high voltage. The tube current will always give you some noise which is acceptable provided you know what you need. The rotation needs to be kept between 1 to 0.5 seconds, and the lower voltage regions will have an inherent tissue contrast. So that area, like the lungs by itself has a very inherent black air and the bones ribs. So here you don't need a very high tissue penetration. Here you can have a low MA because the body itself is giving you a very good contrast. To just give you an example, so this is a patient of neuroblastoma where you need it for staging. In neuroblastoma, you need surgical information as to involvement of the organs associated with it, and that's why you need a dedicated CT. So this is going to be a high MA and a high voltage CT. But similarly, there is a patient of lymphoma where you're not really needing to have information regarding its encasement with the vessels and all. You can just go with a low MA non-contrast CT and make do with using CT only for an attenuation correction. Similarly, like I mentioned, when patients assessing for lung nodules, you need not have an high MA because by itself it has an inherent contrast of the air and the bone surrounding. The nodule which is seen in a low MA will also be seen similarly in a dedicated CT. So you need not have a high MA done here. So these are certain protocols which have been identified in some departments which give a color coding. So you identify when you're taking history taking, what is the weight of the patient, what is a height, and then the CT tubes, and you have a pink. So automatically press the pink button, and this is what is the parameters for acquisition which your machine will be going to. So there are many ways where many machines have tried to identify, make life easier when you're imaging patients, to give you color coding, to give you DRL factors, to give you the A&M card. It's up to you as to what you decide to use. So there are certain tips which we must remember. Please get involved when you're imaging a child. Identify what the investigation is being done. Whether you can make do with giving low dose of both the activity as well as the CT. If it's it's just a follow-up scan, I'm only going to look at a liver which was tackled. Only do a liver scan. Don't do a whole body scan. Reduce the radiation in that format, and try and make the child comfortable. What is most important in imaging a child is making the child comfortable. Allow the parent to come in with the child. Just ask the parent to be away when you're doing the initial CT component. For the rest of the scan, let the child be inside with the child. Give the child a toy. Make the room very comfortable. I can tell you very proudly that in the department at our Tata Memorial, we don't give a child anything other than an oral contrast. We've never done IV sedation for a pediatric child in the last 15 years that we are working here. Vocal anesthesia works. I'll make the child comfortable. If need be, show the child the machine room before going. Tell the child that this is nothing. Your mother will be there. Talk to the child. A child is allowed to be spoken to. All these parameters help the child become comfortable, who will comply very well with the procedures which are being done. After all, we are dealing with a life which is, if well treated, comes out best. So let's try and image the child gently, both in terms of radiation as well as in terms of handling the child well. They are our next generation. Yeah.
How do we decide an Indian population
So the question is, in terms of ENM guidelines and American guidelines, what does India follow? Like we said, we are also not having a very robust system here. We try the balanced out American way, where we try to give less than 26 millibecquerel per kg, which works out better for us, for our patient. Yes.
When you talk about European guidelines or American guidelines, uptake and conditions in which dietary conditions, what their population is having, what Indian reference.
Yes.
So when we really compare, there are certain factors we have to apply to scale down the doses so that, because we directly cannot just copy it and start.
Exactly. Yeah.
Are we doing the same thing?
No. So we don't have any studies which are done for Indian population, but based on the ENM card, which mentioned earlier that you could have about 3.7 millibecquerel to 5 millibecquerel per kg. Similarly, we tried and applied that only to our patient population. We've identified that if we stick to about 20 millibecquerel per, it works for our pediatric population. But we don't have studies for our population. We don't. Yeah. Yes. Okay. Okay.
Where we have taken the data from the autopsy and whatever the
yes.
data
Yes.
we scaled down as reference, as factors and all those things.
Okay.
And we really see that because the type of uptake and type of biokinetics what we are having it.
Yes.
Usually if we started using this particular dosimetry protocols, what our pharmaceutical having, there is a difference.
Yeah, there could be.
Directly you just take care of it, or there is a factor?
No, there is no factor in for specific for Indian population. We don't have that. So the factors which there is no published guideline for our Indian population as well. But yeah, we have found out that whatever we are trying to balance out between both the US as well as the Europe. No, so I don't have a head-to-head comparison done, but from what we are using as a balanced out, we our scans are quite adequate. We see our SUVs also fall into the range of whatever literature is published for different tumors. So I don't have a head-to-head comparison as to the normal organ uptake in the Western population as well as Indian population, but tumor population, like when we look at studies and we say that this could be the SUV range of a neuroblastoma or an SUV range of a Wilms tumor. So that SUV range, even our Indian population studies also fall within that range. So I just know that the tumor volumes, I don't know about normal organ volume, whether the SUV uptakes in our population and the other population might differ. I don't have any data.
Thank you very much, ma'am. That was a very intriguing lecture. We now invite our next speaker, Mr. Amit Nautiyal. He will be delivering the topic, dosimetry in lutetium-177 dotatate therapy. We request our chairperson to kindly introduce the speaker.
Amit Nautiyal is currently working as a clinical scientist at Cromwell Hospital, London. He also serves as a scientific officer in Tata Memorial Hospital. He is the secretary of both CNMSP and NMPI. His area of expertise include radiation dosimetry, molecular imaging, image quantification, and radiation biology. Over to you, Amit.
Thank you, Mom, for the wonderful introduction. Am I audible?
Yes.
My screen is visible?
Yes.
Okay, so it's in presentation mode, right?
Yes.
Yeah, thank you. So yes, today I will be speaking on dosimetry in lutetium dotatate therapy. And in this lecture, I will cover some basic concept about dosimetry and what all are the calculations required. And thereafter, how we perform imaging-based dosimetry and what all are the evaluation has been done. Yes.
We just wait for a few minutes.
Okay.
ये ठीक है सब बराबर है देखा ना नो वन पुट इट डिटेक्टर हां निकाल कंप्यूटर 192 हो जाएगा हां इस गया ओके एक बार नहीं सर एक ही रहते हैं आता है बंद हो जाता है इसी में चल रहा था ना पहले से नहीं नहीं इसमें चल खोल जाएगा
Amit sir, you can continue.
Yeah. Okay. So, so in this lecture, am I audible?
Yeah, you're
Yes.
audible, Amit.
Yeah, thank you. So I will cover basically the basics of dosimetry and what all are the calculations required. And then I will come to the different dosimetry methods and thereafter imaging and which required like SPECT, CT, and multiplanar whole body imaging for the dosimetry purpose and what all are the evolution has been done in aspect of dosimetry and then summary. So let's talk about the basics. So why this dosimetry is required? Because of we all are aware the absorption of energy from the ionizing radiation can cause damage to the living tissue. So therefore, there is a significant role in the nuclear medicine since we are using the isotopes, we are dealing with the ionizing radiation, and there are certain organs which have a specified tolerance limits. So just to protect them and just to take care about them, there is a need of this dosimetry. And this is just a basic formula of absorbed dose. If we talk about, so it's just energy absorbed by per unit mass of tissue, and we can denote it as a one gray. The unit is gray, and 1 gray scale to 1 joule energy, which is deposited per kg tissue and organ. And next is the common unit, which is the CWAT, and we can define it with the help of equivalent dose. And equivalent dose is the quantity that takes into account the relative biological damage caused by the radiation interacting with a particular tissue or organ. So there are the different fitting factors based on the effectiveness of particles or radiation. So now come to the dosimetry methods. So there are two general methods by which we can perform this dosimetry. First one is the standard, this is the absorption fraction method. So we all are aware about MID method, which is the medical internal radiation dose method. And second one is the direct method where you have the dose coefficient and we are just multiplying with the administered activity. So how we calculate radiation dose using the MID method? So there are 3 steps. So first one is to calculate the accumulated activity present within the organ. Thereafter, you are going to calculate the number of emissions from the radioactivity which is present within the organ, their abundance, their fraction, then total amount of radiation energy emitted from each emission. So there could be multiple emission like beta, gamma. So we need to find out the energy being deposited and their abundance. And then next step is the absorption fraction, means how much fraction of energy emitted by the source organ and that is absorbed by the target organ. So first is the cumulated activity, how we can calculate this cumulated activity and what is this? So cumulated activity is nothing, it's just a total number of radiation disintegration occurring over a period of time. So there are two factors, like first one is the amount of activity which is present and another is the length of time inside the organ. So time lapsed by the activity within an organ, this is a unit, becquerel second. And obviously, if high amount of accumulated activity, your absorbed dose will be higher. So there are several assumptions are there. So these assumptions are based on the. So these assumptions are based on the clearance pattern of radiopharmaceuticals from the body. So like if you talk about the first assumption, so if there is a uptake is instantaneous and there is no biological excision, means there is only physical decay. So you can define this. You can define the cumulated activity. You can find out using this standard formula. This is a mean life. This is your physical decay, and you are just multiplying it with the initial activity which is present within organ. So you can see here in this assumption there only physical decay is there, or there is no biological decay, or like in case of, you can say, like in case of tear, yttrium-90 tear. So we can consider this assumption 1 to find out the accumulated activity. So there is second assumption is there, like there is no physical decay, or there is only biological excretion, like we can consider like physical half-life is pretty longer as compared to biological excretion. So in that case, we have to divide. We have to divide this excretion pattern or this cumulated activity with multiple of fractions. Like this is a fraction 1, fraction 2. It could be fraction 3. And obviously, we have to again define the different exponential excretion components, like if activity is going to be excrete with the different exponential, like, so this one is the biological half-life, this is the second biological half-life, it could be third or fourth. In third assumption, like there is uptake is instantaneous, but clearance is by both the physical and biological excretion. So obviously, if you are considering the both, then you have to consider the effective half-life, and this is the standard formula for the estimation of cumulated activity. And this is again, what if you have the more than one component of biological excretion? So it's not a mono exponential. So if the decay is by exponential, so this is the standard formula. Only thing you have, again, you need to find out the fraction of each component, and again, then different effective half-life. You have to if there is a different component of when you need. And assumption is next assumption is if uptake is not instantaneous, or we can say significant amount of physical decay occur during the uptake process. So again, in this step, everything is same. Only just you need to find out the uptake half time. So next thing, how we can calculate this cumulated activity. So there are a number of methods are there, and each one have their own pro and cons. So if you see, so there are direct integration method, least square is there, compartmental and mean half-life estimation, and direct integration is quite easy and it's very easy to perform. You just need to divide your data into number of segments based on the acquisition time and based on the data which you have acquired for different time period. And the only drawback is this direct integration is the overestimation of your accumulated activity, because you do not know what is the pattern thereafter. So only thing is that thereafter you have to consider that there is only physical decay. So obviously there is high chances of the overestimation of your data. And next is the least square analysis. This is a quite popular method for the cumulative activity estimation. So here, what you need to find out, you just need to find out what is the exponential pattern of your activity. So whether it is bi-exponential or it is mono-exponential, it sometimes could be tri-exponential as well. So only thing is you just need a best fitting curve here, and then you are calculating the activity which is present within this area or area under this curve. And next is the compartmental analysis. So here, obviously, it's very difficult to perform manually. So only you can perform it using, there are a number of softwares are available. Like this one is the SAM3. So you have to divide your organs in different compartments, and then you need to find out what is your rate of clearance, your rate of absorption, distribution, then redistribution, and then you can calculate the accumulated activity. And if we have the accumulated activity, so next step is to find out the equilibrium absorbed dose constant. So this is just the energy which is going to be emitted by the accumulated activity which is present within the organ. So these are the standard formula based on the old unit and SI units. And Ni, this one is the number of emission, and here your energy of each emission. And next is the absorb fraction. So we have everything. We know the cumulated activity. We know the energy which is going to be absorbed. So obviously, if it is gamma energy, there is high chances that fraction of this energy is going to be emitted, or it is going to be absorbed by the target organ or nearby organ. So in that case, it's very important to consider this factor as well, which is absorb fraction. So if you have the absorb fraction, so you have your accumulated activity, you have the equivalent absorbed dose constant, and you have the absorb fraction as well. So what would be your final calculation? Calculation for absorbed dose. So this one will be your final calculation, energy absorbed by per unit mass of tissue. So this is your formula for the energy going to be absorbed. This is your mass of tissue. And if you separate this section cumulated activity, so this entire sections you can term it as a S value. And it is this S values are quite popular and it's easily available, and you can find out and you can see them in many documents online as well. So now come to the dosimetry imaging. So this is your clinical dosimetry workflow, how we can perform if we have a clinical setup, how we can go for the dosimetry of lutetium 177.10. So first thing which is very important is which system you are using and what is the sensitivity of that system. That also is really important. Then so you have to find out the sensitivity of system. Then you need to calculate the different time points just to take out the activity from an organ from different time points. So obviously you need the different image acquisition, regional acquisition or whole body acquisition. And then you have to perform the reconstruction and all the corrections, which are attenuation correction or scatter correction. Then you have to register with the CT images. And then you need to find out the time activity curve. And thereafter is the accumulated activity. If you have the time activity curve, you can easily find out the accumulated activity, and then it's very easy to find out the absorbed dose. So this is the just a overview how you can find out the accumulated activity, or how you can find out the area under the curve, we can say in the practical aspects. So these are your time points, number of images which you have acquired over a period of times. So this one is your first time points, imaging time point. This is your second imaging point. This is your third time point. So you can clearly see. So here the activities all. Obviously, this activity is going to be decreased just because of there could be effective half-life, just because of effective half-life. So you can see the pattern of curve. So it's plummeting here. And then if you have all the time points, if you have the area, then you can easily find out the area under this curve. And what all are the next thing is the different imaging scenario, which imaging scenario you should use. So obviously the accuracy of dosimetry again depend upon all these imaging scenario. So if you talk about the SPECT image SPECT scenario, so in the SPECT scenario, what you are doing? In SPECT scenario, you are considering all the things like, in this case, you can see you are segregating one organ from the another. So it's, you can say it's a more accurate method as compared to the hybrid and the planar. So in planar method, you can see if you are going to calculate the dose of the lung. So obviously there is a chance of the higher or overestimation of the accumulated activity or absorbed dose just because of this overlapping region. So because we are also considering that some part of liver as well. So in this point of view, you can see that this method is quite popular SPECT based method. So because you can easily segment them, you can easily delineate, and you can easily segregate the organs as well. So, but obviously again, this SPECT to acquire the SPECT images for a number of period or a number of time over a period of time, it's quite time consuming because patients has to lie down for 45 minutes or 1 hour just for a single session or for a specific dosimetry scans. So in that case, there could be a trade-off where we can use the hybrid dosimetry method. So you are basically using the planar whole body images along with one single session of SPECT images. And then you can correct the overlapping region, and based on that, you can correct and you can put the activity, what is the differences there, you can implement or integrate it within the calculations. So this is just a representative final report of processing software. So this is the standard processing software with the report being generated by JhaSchools toolkit software. These are the number of images are there. So these are the planar delineation of organs. And this is your best of fitting using exponential fitting, you can say, and this is your residence time, which you need to put or you need to enter within the Olinda software. So this is a software assisted dosimetry, we can say, because then obviously if we have all the data, we know the residence time, we can term it as a normalized cumulated activity. So if you have all this data, you can enter all these values within this Olinda software. So there are a different number of questions are there. So the main input parameters which is required for the estimation of absorbed dose are you need to select the which type of radionuclide you are going to use. Then you need to select the gender, whether male or female, and then you need to enter the residence time or normalized cumulated activity. You need to calculate the organ mass, because all these values which are there by default, they are based on the standard MIR phantom, or we can say standard human models. So you need to change all these values and to calculate the more precise dosimetry, just to interpret more precise dosimetry results. And within this software, there are multiple models are there, like sphere model, bladder model, or gastrointestinal model. So now next come to the recent development. So what has been done in case of if you are talking about the lutetium dotatate dosimetry? So what all are the evolution has been done? So this method is quite popular, this voxel-based dosimetry. We all are aware about it. So this is a 3D image-based dosimetry techniques for voxel by voxel absorbed dose calculation. So what we are doing, you are dividing all your data into number of voxels, and within these voxels, what you are considering, you are considering one specific voxel as a source voxel, or a source organ, or nearby voxel as a target organ or a target voxel. And then you need to calculate the time activity curve for each of these voxel, and then integral of activity just to find out the cumulated activity. And then you can convert this cumulated activity into absorbed dose by considering the energy emitted by radionuclide will either be deposited within this voxel, or it is going to be deposited to the neighbor pig voxel. So all these things you can perform using the simulations, this Excel. And the simulation technique, which is quite popular at dose point Karnar method and Monte Carlo simulation method. So what could be your practical approach for voxel-based dosimetry? So you first need to calculate the multiple quantitative spectricity. Then you need to register them with the CT images, and then you need to find out the voxel kinetics, the time activity curve from each voxel. Then you need to calculate this dose calculation. So simply you are just going to calculate absorbed dose using your cumulated activity, which is present within the particular voxels using the simulation techniques. And so they are assumed to be equivalent to the water, and thereafter you can estimate the dose by convol through activity array. So you can see this is your voxel kinetics. You are calculating this voxel kinetics. You are calculating this one is for each of your voxels. And this is your simulation data. And then you are calculating this dose for per voxel. So you can see, because so here you can see what is the advantage you can see as compared to the traditional method. So what you are considering here, you are considering the heterogeneity of activity as well. But in the general methods, if we see, we usually do not consider heterogeneity of activity. What we are considering, like in Olinda software, we are considering that the activity is uniformly distributed within the organ, but that is not the case of actual scenario. So it may vary from, you can see from the in particular voxel, it could be higher, in somewhere in the same organ, it could be less. So what is the limitations of this voxel-based dosimetry? So the main limitations is you are considering the homogeneous tissue. Again, homogeneous tissue, you are considering that all the tissue are homogeneous, their density is same, and obviously the resolution of spect. So it's very difficult to people are working on it just to improve the resolution of spect images, but we are talking about sodium iodide detector and these things, then obviously the resolution is not so good. And then again, the registration accuracy, and then again, the kinetics fitting, which we are using. So obviously all these are the factors which influence our dosimetry results. So just then again, why this concept? So another concept has come, like direct Monte Carlo simulation. So why this concept has come? So this concept has come just because in that voxel-based dosimetry, we were not considering the homogeneous tissues. So, but in this direct Monte Carlo simulations, we are considering the homogeneity of particular tissue. So how you are considering? So here, what you are doing, you are taking the all patient CT data. So this CT data, we are taking this patient CT data from each of patients. Why you are taking this? Just to create a mathematical voxelized phantom. So if you are taking all the CT data, the Hounsfield unit, and then obviously you can say that dosimetry data and the dosimetry which you are performing would be more precise as compared to the conventional dosimetry techniques. So here you are considering the density specific dose map and this dose map. So if you have the time activity curve, you have the density specific dose map. So you are just convoluting it with them, and then you can find out the absorbed dose to a particular organ or tissue or tumor as well. So these Monte Carlo methods represent a gold standard for absorbed dose modeling, as it is capable of simulate all physical effects relevant for the absorbed dose deposition. So this is just a workflow how this direct Monte Carlo simulation works. So at same time you are considering the patient anatomy, same time you are considering the patient kinetics from each the voxel. So what you are doing here, you are considering the tissue heterogeneity, as well as you are also considering the heterogeneity of activity within the organs. Obviously the dose which we are going to, the final calculated dose will be more precise as compared to other methods. So the advantage is potentially accurate than organ-based dosimetry because it considers the anatomical variation in each individual and heterogeneous activity distribution within the organ. So because what was the major drawback of this direct Monte Carlo simulation? It's quite time consuming because it is simulating each of the emission within that voxel. So it's so obviously in the routine clinical practice, it's very difficult to implement this one. So that's why the concept of dose point kernel method is come. So those are there is pre-calculated, or you can say the pre-calculated S values. So what we are doing is everything is same. We are going for the voxel by voxel. So only thing is the pre-calculated dose point kernel values which are there. So we are just convoluting them with the cumulated activity presented within the each voxel. So if we talk about the overview of the different dosimetry methods, so as I said, this one is the Monte Carlo simulation is the gold standard methods, and you can say it's very accurate as well and can handle the multiple issues and heterogeneities as well. But the only drawback, it is many simulation parameters, and then it's complex and time consuming. So that's why the concept of this S value and this dose point kernel is come. So we can say is that they are the less time consuming and compared to a Monte Carlo simulation. So another people are working on another method, which is deep learning based dosimetry. So in deep learning, this concept is also come just to minimize the time of direct Monte Carlo simulation, because it's very difficult, as I said, so time consuming this direct Monte Carlo simulation. So this concept is come to just perform the dosimetry based on the deep learning method. So in this is also the same voxel scale MIRD approach. Everything is same. Only thing is you are just considering a deep neural network to predict the distribution of deposited energy. So what you are doing in this aspect, you are generating a training data set, which will consist of the different density map, dose related density map obtained from the CT images. So you are making a training data set, and then from that training data sets, if you have everything, you have the voxel based, and you have the cumulated activity calculated from the voxel. So you can easily implement this neural network with this. You can convolute, and then you can find out that absorbed dose. So obviously, as compared to all these methods, you can see as value dose kernel, this method will be quite good, because here what we are doing, we are considering tissue heterogeneity as well, because we are
using the training data set which have all those parameters or all the density map based on the patient the density which vary from which vary from the patient to patient, the density which vary from patient to patient. So this is just a general workflow of deep learning based dosimetry. So first step is to find out the specific S value kernel. You are just predicting the specific S value kernel using deep neural network. And second step is your patient specific dose map calculations. So you are calculating the dose map using your deep neural network. So in this step, what you are considering the medium specific dose distribution. So medium specific, what does this mean? The medium specific means you are considering the tissue density as well here. So everything is based on the your training model, and people are working on it, and we are hope so that this method we would be able to implement in near future. So advantage of this technique is consider heterogeneity of activity, distribution and non-uniformity of surrounding medium, and patient-specific anatomy. It's also consider the patient-specific anatomy using deep learning algorithm, and it is less time taking compared to the Monte Carlo simulations. And another method which is quite popular is single time point based dosimetry in case of lutetium 177 data therapy. So here what you are doing, you are calculating this dosimetry using a single imaging time point. So here what you are doing, you are just assuming a mono exponential decay from a particular organ or tissue, and you are just approximating it. And just this is a standard formula just for the approximation, and then you are finding out the area under the curve and the absorbed dose. And another method of this single time point dosimetry is just to find the mean effective half-life from a large populations. And thereafter, you are just using this mean effective half-life for the different organs and tissues. So mean effective half-life, we need to calculate it for a tumor, for liver, for different organs. So for whatever, if you are going to perform the dosimetry for kidneys or liver, whatever organs, so you need to calculate this mean effective half-life separately for particular organ from a large population, and then you can calculate that this normalized cumulative activity, and thereafter you just need to feed it into the Olinda software. So the next concept is the intraarterial versus the intravenous PRRT in case of lutetium 177 data therapy. So if you see the disadvantage of, because we all are aware we are using this intravenous injection for all these our administrations, so that the major disadvantage is for this therapy lies in the fact that substantial dose proportion is dissipated within the systematic circulations, and hence a reduced dose impact reaches the tumor. So if you compare them, on the other hand, the administrating the dose intraarterially, a high concentration of percentage is expected to reach the tumor, and consecutively a high delivered absorbed dose and tumor destroyed with lowest possible delivered dose to the kidney. So there are two advantages. First is the higher absorbed dose being delivered of your dotatate. And another thing is like your tumor is obviously high dose and tumor destroys. So tumors destroy, and then obviously because more dose being delivered to a particular tumor, then there is a lowest possible delivered dose to your kidneys. So obviously if your dose is less to the kidneys, which is the major critical organ in lutetium dotatate therapy, you can increase the number of treatment cycles or activity as well, the administered activity. And this is just the distance. If you see the intraarterial, what is happening, the distance, dorsal vein hand system, the antecubital vein up to the liver tumor is more than 3-fold longer compared to the distance which we are using, like in case of intraarterial therapy. So in case of IV administration, the distance being activity, which is traveling to reach that particular target tissue, is 3-fold longer. So dosimetry point of view, if you see the intraarterial technique, so intraarterial administration result in a higher activity concentration in liver metastasis, which subsequently lead to 2 to 3 times higher absorbed dose compared to the IV administration.
And it has the lesser renal dose, and then we can increase because we have the lesser renal dose. And if the dose is within the tolerance limits, obvious, then you can further go for the more number of treatment cycle. And next one is the bone marrow dosimetry. So there are multiple techniques, like there is a in vitro techniques or imaging techniques. So everything is same. In case of in vitro technique, you need to collect the blood, and then you need to find out the activity presented in presented within the red marrow sections or red part, and then you need to calculate the activity from the different samples, blood samples which you have collected, then cumulated activity, and then finally you can find out the absorbed dose. And in case of the imaging method, you just need to draw a RY from a particular section. So usually you can choose the longer bones, or like you can choose the femur, or you can choose the lumbar vertebra as well. And simple, thereafter you need to find out the activity and then cumulated activity, and then you can go for the standard a technique like normalized cumulated activity and absorbed dose calculation. So if you come to the summary. So there are a number of methods people have used for this dosimetry, and there are a number of articles are available online. So if you see the overall period of times, like the first dosimetry which was performed in 2007. So if you see till date, so many scientists and researchers are working on it just to make this dosimetry, to make it simple and convenient, so that we all can use it, and we can implement this in routine clinical practice. So if you see in first study, which was performed in 2007, they performed the dosimetry calculation by two different radiopeptides. One was DOTA-TAT, one was DOTA-NOC. So they just used the planar images and home system. So what they have found, there is a lot of variation. So what they have found, this variation was mainly due to the high intra and inter-patient variability. So what they have concluded, that there is a need of perform this dosimetry for each patient, or we can say the individualized patient dosimetry. So in another study, they have in 2013, they investigate the most adequate timings, how many number of time points required, and what all are the most adequate timing, whether we need to perform it at 30 minutes, 4 hour, 24 hour, and for how long So they did the spectroscopy images for different time points. So what they have concluded, they have found out that data should be collected at least for 100 hours in case of lutetium therapy. And then in another study, 2016, they estimate the radiation absorbed dose to the dose limiting organs, and these are the values. They have generated the dose, like the highest absorbed dose being delivered to the kidneys, and followed by spleen, then liver, and then marrow. In 2017, one study was performed, so they've just compared the different imaging scenarios. So in that imaging scenarios, what they have concluded, that spectroscopy-based imaging scenario significantly produce lower absorbed dose compared to the planar scintigraphy method. And then couple of evaluations, couple of studies are there. If you see here, they have in 2017, they used single time points for the renal dosimetry purpose. They just performed the hybrid imaging. And what they have concluded, that dosimetry based on the PRIT is feasible and safe up to 7 cycles. So we can go up to 7 cycles if we are going to treat the patient. And in another study in 2017 published in A&M, so they have found out that automated tumor segmented, if you are using automated tumor segmentation or delineation, so it results in larger dose than the manual segmentation technique. And in a study which is published in 2018, so this study was aim was just to find out the alternative imaging protocol for clinics that are unable to perform multiple time points acquisition. Like there are many departments which are quite very busy. So in that case, what they have found out, the dose estimates for the kidney made from the single time point imaging are feasible and more accurate when derived from the 24 hours. So this is just for the kidneys, because most of the changes, if you see that there are a couple of variations in the activity within the kidney, because activity is excreting very fast from the kidney within first 24 hours. So it's very important to consider these time points, and then you can calculate the renal dose as well using the single time points. And then in 2020, one study was published in EJNAM, and they have found out that nuclear medicine community has to agree on an accepted and validated dosimetry methodology available for majority of centers. So there is a need, there is a requirement of this dosimetry in routine clinical practice. And in 2020, another study was introduced with the aim of simplify this dosimetry measurement. So what they have done, they also calculate the fractional contribution. So what they have found out, if you see the fractions on different fractions, means how much, which fraction is inducing how much absorbed dose or which fraction is responsible for the specific dose. If you see the fraction 0 to 24 hours is contribute around 26% absorbed dose. And then these are the 96 to infinity. If you see, it's around 28% contribution to the total absorbed dose. And then dosimetry with another study in 2021 with dosimetry with 3 different approaches. So what they have found out that, this is behind. Yes, this one is my last slide after this. So what they have found out that the combined approach was determined to be valuable with utilized 2 dose calculations methods. So there is a need of combined approach where you are considering the tissue heterogeneity and you are also considering the heterogeneity of activity within the organ. And then in 2022, recently one study was published in the JNM. So they have performed, they just assess the changes in the tumor absorbed dose with respect to the tumor grading. So they have found out that with the tumor grading also this absorbed dose changes. And this is most likely due to the radiation-induced fibrosis. So what is the take-home messages? So an individualized patient dosimetry is required in lutetium-177 dotatate therapy to determine the maximum administered activity and number of treatment cycle. And all the body organs have different tolerance limits. So there is a certain limits, and kidney as a major critical organ in lutetium-177 dotatate therapy. And same time, one has to note when you are performing dosimetry that accuracy of this dosimetry is limited. Therefore, absorbed dose of organ might be underestimated or might be overestimated. And then selection of technical parameter is important, your sensitivity of your system. And then for more reliable dosimetry, voxel-based approach, dual technique with quantitative specificity is recommended. Thank you for hearing and your patience. Thank you. If you have any questions, you can direct me. I guess we have the time constraint. So if you have any questions, you can write it to me and I will try to reach out to you as soon as possible. Thank you.
Thanks, Amit. Very nice talk.
Thank you very much, sir. That was a very informative demonstration. Moving forward, we now take this opportunity to indulge you all into the second session for the day. This session is based on the practices and regulations in nuclear medicine. And for this session, we invite our chairpersons, Dr. Anshu Sharma, Dr. Sharmila Banerjee, and Dr. E. Prabhu.
Our chairpersons for this session are all well-known and dynamic personalities in the field of nuclear medicine. They need no special introduction since they all have been great contribution to the field. Dr. Anshu Sharma is a consultant and head of nuclear medicine and PET-CT department at Kokilabein Ambani Hospital. From the last 3 decades, he is serving this community tirelessly with his extensive clinical experience in diagnostic and therapeutic nuclear medicine. We welcome you, sir.
Dr. Sharmila Banerjee is a professor in nuclear medicine at ACTREC HBNI and also chairman of Radiopharmaceutical Committee, DAE. She has also served as head of RMC BARC and as a senior general manager of medical cyclotron facility. She was the IAEA expert for several years. We welcome you, ma'am. Dr. E. Prabhu is a senior consultant and head of the Department of Nuclear Medicine at the Tamil Nadu Government Multi-Super Speciality Hospital, Chennai. We welcome you, sir.
A great round of applause for all our chairpersons for this session. During this session, we have some interesting lectures regarding ELORA, the highly debatable discussion about pregnant radiation professionals and radiation exposure to them. So respectable guests and delegates, Please lend your kind attention to our speakers for this exciting session. But before all of that, we kindly request all our speakers to be on time since we are running behind schedule. Over to you, Chairperson.
You are not audible, sir.
Am I audible? Yeah. You're audible now? Am I audible now?
Yeah, you are audible. You are audible now. Yes.
Thank you. So we start the session without any delay. I give now the mic to my co-chair, Dr. E. Prabhu.
Thank you, Dr. Pranshu and Dr. Sharmila, and my dear young friends. It's a great opportunity to meet you all. But we are all interested to have a best quality, good quality nuclear medicine, good quality images. That's what we are all working. But then, what is quality? You don't know. We say that this is quality, that is quality. So there was a uniform consensus, and the NABH has come forward to recognize that we are following certain qualities and guidelines. And to expand more about it, we are going to have Dr. DJ Prachar from Ghaziabad. He'll be talking about the second edition. First edition, a lot of interesting developments are happening based on our experience. The second edition has come, and there are a lot of interesting scoring systems. And in order to make quality more objective, there were 1, 2, 3, 4, 5 points given. All the points are added up. Average of 10 points was taken as quality to be granted, and there was no subjectiveness as much as possible. And let us hear more about it from our speakers. Over to Dr. Divya Prakash. Please go ahead.
Divya Prakash, sir, you can now share your screen.
Sir, please unmute yourself.
Go ahead, Dr. Divya. Please go ahead. You are not audible. Divya sir, you are not audible. The slides are visible. Can you unmute yourself?
Divya, you are unmuted, but I think you will have to remove your this microphone. So use mic from your laptop itself.
You're mute too, yes.
Yeah.
Am I audible now? Hello. Hello.
Yes, sir, you're audible.
Now audible. Okay.
Share your screen, please.
Is it okay now?
Yes, please go ahead.
Okay. Okay.
Yes, sir.
Okay. So the topic which I have been allotted is NABH accreditation for the second edition of standards and the new rules of accreditation validity. So we have already spoken on the NABH topic on the CNMST platform, and we discussed what is NABH, we discussed what is quality, what is JCI, what is accreditation, what is quality indicators. So those all the things we have already discussed, and that video is already there on YouTube. So if someone wanted, that can be viewed, and that is a quite long video, 57 minutes video. So people can refer that. So here we will be discussing only about whatever that presentation was done on 9th of August 2020. So whatever changes has happened since then, that we are going to discuss here, and whatever the new rules, whatever new standards have come, that we are going to discuss in this presentation. And my I'll try my best so that if anyone new person is entering in for the NABH, for the MIS services, they should get a little knowledge about how to proceed with the NABH process and all those making policies and SOPs. So that I'm trying to cover this in the presentation. So this is the second edition of standards which has been published in the December 2019 edition from the NABH for MIS services. MIS means medical imaging services. So they call it MIS. So this is the second edition, and this was to be published in December 19 and was to come into the effect from 1st January 2020. But the effect because of COVID and all, this was delayed, and this has affected from 1st January 2021. The previous edition was issued in December 2015, and surprisingly, that was also second edition. I'm sure NABH must be having some justification for why that was also second edition and this is also second edition. But in this edition, they call that as a first edition. So I'll stick to that, and I'll call that as a first edition and this as a second edition. But for the hospitals, they have continuously increased their edition number, and the edition which was issued in April 2020, that they call it as a fifth edition. But for the MIS services, it is the second edition of the standards.
आप कितनी देर में निकलोगे? मतलब क्या है आपका यहाँ पे मेकअप होगा? हैं? मेकअप होगा यहाँ पे? मेकअप? पतला हो गया मैं? अब ऐसे
Audience can mute
लग रही हो
yourself.
मेकअप?
Okay, so comparing both the editions, first edition had 6 chapters, whereas this new edition has got 7 chapters of their standards. What they do, they formulate all the standards and then they divide that in different chapters depending upon whatever relevant to what. So based on that, they had around 6 chapters in first edition, and the name of chapters were control of services, control of imaging processes and procedures, control of personnel, control of equipment, control of documents and records, and the 6th chapter was risk control and safety. Whereas in this edition, the names of the chapters have entirely changed, and it is like access, assessment, and care of patients. The second chapter is imaging procedures and interpretation. facility management services, equipment, material, and medications, human resource management. The 6th chapter is management of quality and safety. And then in the 7th chapters, they say about information management system. So these are the 7 chapters. They have divided their standards, and regarding their standard elements, whatever the standard points they call them as a objective element. And in the first edition, they had around 651 objective elements, whereas in this edition, they have only 214 objective elements. This doesn't mean that they have reduced the standards or they have compromised somewhere. What they have done, they have merged some 2-3 objective elements into one, or wherever there was some repetition, that they have eliminated, and they have completely restructured their standards, and they have come up with this 214 points that one need to follow. And out of that, those 214, they have 34 in core category, and this they say that it should be followed on each occasion. Means whatever assessment is going to happen, like pre-assessment, final assessment, or surveillance assessment, or any re-accreditation is going to take place. In all the assessments, this has to be there whenever you are going for any assessment. So on these 34 categories, 34 standards will be seen all the times. So, and this 157 points they are going to see during the final assessment. This 17 points they are going to see during the surveillance assessment, and the 6 are going to be seen during the re-accreditation process. Because the NABS says that quality is a journey. It's not an achievement, or it's not a success. It's the process. And on each occasion, we should move forward. So they have increased their standards from the last time. On each occasion, they have continuously increasing. What they say, whatever yesterday you were there, today you should improve upon the quality, and again tomorrow there should be some new additions in your quality parameters. So likewise, they have formed some 214 objective elements, and these 214 has been divided into the 7 chapters. So what are the purpose of these standards? Why NABH wants these all the things to be followed? They wanted an improved patient safety and quality of care. They wanted the patient information should be improved. They always say about putting all these signages, and it should be bilingual. The fire signages should be there. The direction signages should be there. All the labels should be everywhere. So information system has to be very good. So that they wanted to improve, and they wanted the patient right to be protected. The rights and responsibility should be displayed, and it should be bilingual. So these all the things they wanted to improve. They also want the staff satisfaction should be improved with the safe and efficient work environment. And they also want an effective and efficient management system for the medical imaging services. They also wanted to ensure various legal and regulatory compliances are adhered with. If you're following all the rules and regulations, there are many things which can be covered and which can be followed. So many things cover all these. All the safety parameters are covered if you are following all those rules from the regulatory authorities or from the legal compliances. So that they wanted to ensure, and they also wanted to provide some quality framework for insurance or empanelments, like someone like CGHS or ACHS or ESI empanelments. If they wanted to judge some organization that they wanted to send the clientele there or not, so there should be some quality parameters, or there should be some organization which should authenticate that this organization following some quality. So that role the NABH does. So these all are the purposes of their standards. And let's begin with the chapters which they mention in their in this standard. So beginning with the chapter 1, which says the access, assessment, and the care of patient. Every chapter has got the intent of chapter. They at the beginning of the chapter they say what this chapter intend for, and then they summarize the standards. In the chapter 1, like they have given 8 points 8 main points they have given, and then these points has been subcategorized into further subdivisions, and that then again this point number 2 that has been given around the 5 points, like every chapter, every standard has been subcategorized. So now this all the books we have, and suppose we are going for the NABH accreditation, so how our approach should be. So when I was making the documents or the policies, what I did, I took, like they say in the first chapter, the organization defines and displays the scope of medical imaging services that it provides. Means they wanted the scope of services to be displayed, and within that they wanted the 3 points: the scope of medical imaging services being provided are clearly defined and prominently displayed. So this they wanted, and on the point number 2, they wanted the patients are accepted only if the organization can provide the required medical imaging services. On the point number 3, they say the staff is oriented to the medical imaging services, means the staff should be aware about the what are the services you are providing. So while making the policies, what I did, I simply wrote on the point number 1 the scope of medical service, scope of medical imaging services, and then the point number 1.1 display of scope of medical imaging services. Point number 2, patients acceptance criteria for medical imaging services. Point number 3, staff orientation about medical imaging services. We need to write all these things. So whatever you're following in the organization, that we need to write. So that forms a policy. So unlike that, we are whatever patient registration process we have, generation of unique identification numbers on subsequent visits, like that they have all pointed in all their chapters. So we need to take all those on our policies, and one by one we need to define. So this makes the work easy for the assessor also. They also see the book, and then they are seeing your policy. Whatever the policy is there or not, that can be seen. So like that, we need to make all the 7 policy for all those 7 chapters. So 7 policies, major policies for this, like equipment, material, medication, how they're going to take place, and human resources management, how it is going to be managed. Like that, there are 7 chapters, so 7 policies, major policies will be there. And based on those policies, we need to make standard operating procedures. So these are all the policies, and how those policies are going to come into the effect. For that, we need to have the standard operating procedures, and the standard of SOPs we should have for the infection control. We should have a SOP for biomedical waste disposal, for the rooms cleaning, for the equipment cleaning and disinfection. We should have a policy for needle-stick injury. We should have a SOP for handling infectious patients. There are various committees or forms. So how those committees are going to operate, what are the quality indicators should be there, and how those quality indicators should be monitored, that is going to be formed in a SOP. And then routine inspection and maintenance of fire extinguishers. And we should have a SOP for internal and external verification of reports. Quality of images, we need to verify what the process should be there for verification of quality of images, and then appropriateness of protocols, how often the protocol should be verified or it should be changed. So what is the policy for that, and what is the policy for handling the clinically irrelevant and relevant and irrelevant discordances. So reports are to be verified internally as well as externally. So what are the policies, what are the SOPs, on what basis these all the things should be followed in the organization, that we need to define in our SOPs. Once the policies and SOPs are in place, we need to make the files, we need to make the documents to prove that they are in the system, they are being followed. So the list of files, if we can say, there are 7 chapters, 7 policies are there, they are named here. And then whatever the subsequent amendments will take place, that will be filed in that file. Then we should have a next file for standard operating procedures. Then we can have a file for quality indicators. We can have file for quality indicators data collection. We should have a file for training, for the NABH correspondences. We should have a list and scope of committees, whereas minutes of committees, committee meetings, that to be filed in a file. Then the material data set in data sheet. Then incident reporting forms, staff suggestion form, referring physician feedback forms. These are the files we need to make. Then the lead gown maintenance conference theme is presentation, the file for that. DG correspondence like this, blah blah. All these files we need to make. Once these files are there, then we need to make many registers. We should have a register for temperature and humidity log register for gamma camera. For the PET CT, we should have a register for FDG inventory. For the other isotopes, we should have a register for these all the things we have in the department. Just we need to organize those all the things like daily radiation survey register, electrical and fire safety round book, record of CT films. We should have a record of repeat PET CT scan, because all these lead to the financial burden to the organization. So they all comes under quality indicators. So that recording we need to have record of contrast reactions, record of daily contrast residual, record of report discussion, record of infectious patients, record of pregnancy check, amendment of reports record, infectious control record, record of critical reports. There are many reports which we need to intimate to the referring physician immediately. So the record of that we need to have. Like that, there are a number of registers we need to form. Apart from that, also some registers, every time it happens, the assessor will ask for some other register which you do not have. This also happens. Then we need to have some memorandum of understanding, MOUs, like if the diagnostic facility does not have an ambulance, they can have a MOU for ambulance. That can be from some hospital or some organization which is providing the ambulance. So MOU should be there. And being an imaging services, we should have a MOU for the ICU services or for the critical care if some emergency takes place. So for that we should have an MOU. And some, if anesthesia studies, some studies if you are undertaking with the anesthetist, so we should have MOU for the anesthesia, which we can have MOU with the cardiologist for the TMT and for the stress thallium, though the nuclear medicine physicians, they are authorized to do TMTs and this is stress thallium. But still, if you wanted to have a MOU with the cardiologist, that also you can have. And then we should have a MOU for external verification of reports, and from that should be from some NABH accredited center, because the reports are to be verified internally as well as externally. Our report should be sent for the quality purpose to the other organization. They should verify, and whatever discordances are there, whatever the interpretation differences are there, that should be come into the conclusion. Whatever the addendum reports are, if you're issuing based on that, so that we should have a record of that. Once we are ready with all these documentation, files, registers, policies, SOPs, we are filing for the application for NABH. Then we should submit all those documents to the NABH on their portal, and we should fill this self-assessment toolkit come score sheet. In this score sheet, they are asking for all these 214 points one by one, and they're asking whether the system is there or not. If the system is there, whether the implementation is there or not, and how much is implemented. It is partially implemented, it is fully implemented, and then you need to give for the scores from 1 to 5, means how much implementation is there. So based on all this, once you file this, the assessor comes, and then assessor again verifies all these, and this is the Excel sheet has got column for assessor, who again fill all those points at the time of assessment. Whether the system is in place, they verify whether it is there in the place or not, whether the evidence for those implementation are there or not, and they again give scores for that. And based on these scores and all, we are given NABH accreditation. So they give some non-conformities, and then once we close all those non-conformities, we are giving this NABH certification. So the new rule for the NABH certification is they are allowing it for 4 years of validity. Earlier, from the last year, it was 3 years validity, and now it is 4 years of validity for the NABH accreditation. And there's some nonsense things also they are doing now, because they say that if it is a PET CT system, so we cannot give accreditation for CT system. We asked why, because AERB says if it is a PET CT system, you can do CTs, and we are authorized to do CTs, and we are all following all the quality parameters for the CT imaging. But then also say this is since the license is for PET CT, we cannot give you a NABH accreditation for CT imaging. luckily we had one new installation for CT machines, so we submitted all the licenses for that CT machine, then they authorized. And another thing what they are saying that since the authorization is given for a SPECT machine, we will not give NABH accreditation for planar gamma cameras, because say the authorization is only for the SPECT, so we cannot give you planar gamma cameras. So this is second, and when we say that the AERB says or the machine itself is a gamma camera, is a SPECT, both it cannot be differentiated. Earlier, it was in earlier time when a SPECT or the planar gamma cameras were different. Now they are one machine, but they say no, we cannot give you. I said okay, fine. And now the third thing what they are saying that for high dose therapies they will not give you accreditation. I said why? So they say we do not have mechanism for assessment for the high dose therapy. I was saying the assessment, who is a very experienced nuclear medicine physician, he is seeing all the high dose therapy facility, all the rules are being followed, all the quality parameters are being followed. Delay decay tank he is seeing, all the waste disposals he is seeing, and at the last you were saying that you will not be accrediting for the SPECT city for the high dose therapies. So they will not do. Okay, fine, don't do. So finally they give this much of accreditation. We said okay, and this is the timeline they are giving, that on 23 to 24 months from the accreditation, that is the timeline from 21 to 24 months, they will be again going for the surveillance assessment, and when there is 6 months remaining from the 4 years, that is from T plus 42, that time we need to apply for re-accreditation. So this is all about the new rules and the second standards of MIS. Thank you so much. Over to you, sir. If any question, please come.
Divya, I have a question.
Yeah. Yes, ma'am.
So what I want to ask is, in case of NABH, NABL, how well are these all these regulations that are there in NABL correlating with international norms?
Ma'am, they're always trying to, because they are authorized from some ISQA organization, that is an international organization. So whatever ISQA proposes, they are following that norms only. So it is international only, and NABH has got some international branches also. So they are accrediting some overseas organizations also. So those standards are as per international now. Because Ansu sir will be able to tell you in a better way. Because he and Prabhu sir both are assessors. So those standards are, as per my belief, it is as per standards, international standards.
Okay. JCA is there. Those
I can't hear you.
Yeah. JCA is there. It is designed to treat. Okay.
Yeah, now you can.
It is designed to treat American patients as per their norms. European standards are there for treat Europeans as per their norms. These are our Indian standards. This is to treat our patients as per our norms. So this quality is an evolving process. It doesn't mean that we have to follow what is being followed in America, what is being followed in Europe. But then all these accreditation bodies, they are all accredited to ISQA. There's an international body that ensures that it is continuously evolved. There are certain standards which are being evolved at defined time frames, and how many institutions are getting accredited. There are so many norms that are not. So we are definitely following international standards, but these standards are to number 3 is that NABH doesn't say that you have to follow this, you have to follow that. It is something like a referee. You are frame the rules of the game. You are telling this is how I am going to do the imaging process. And NABH comes and says that whether it is acceptable as per the very objective or it is certain common minimum standards are being followed. That's what it is.
I will add upon that actually what you ask is, as far as standards are concerned, we have IS standard 15189. Those are ISO standards. But actually what he is trying to tell is correct. Your question was a valid question. We are not following any international standards. ISO is an organization which they follow it. But as far as NEBL, if you go and if you ask for path labs and all those things, medical, then there is 1518 and IS standards are there. That is international standard. So whatever the certificate which are going to be issued by NABL, that is valid internationally. NABL certificate is not valid internationally. Whatever reports are, this is the difference between these.
Thank you, sir. Thank you very much. Thank you, Divya.
Thank you.
Thank you, Divya. Very nice presentation. Now we move to the next presentation. Our next speaker is physically present amongst us, and I think a very renowned nuclear medicine professional. We all know him, dear to us, Dr. Pankaj Tandon. Pankaj Tandon, sir, is basically Central Public Information Officer currently and head Medicine Application Section, Radiological Safety Division, ARD. And I think he has been associated with nuclear medicine fraternity for the last 30 years. We have been listening him quite often. And today he will be speaking on us very important topic, revisit of human resource requirement considering the recent advances in nuclear medicine. Let's hear Dr. Pankaj Tandon. Over to you, sir.
Thank you very much.
Dr. Pankaj Tandon, myself, Nanshu, all three are from NABH, where we are principal.
Thank you very much, sir. Thank you very much for such a nice introduction. Actually, hope I am audible to those who have attached with us from the virtual. Am I audible?
Yes.
Yeah, thank you very much. First of all, I am really thankful to NMPI who has given me an opportunity to be with you, and this is 6th annual conference, and I am privileged that I am attending since the first started from AIMS. And I really feel too good whenever I associated with this particular fraternity. As Dr. Anshu has told me, has introduced that, yes, I am associated with nuclear medicine from last 28 years. And I love particularly this field. So when I'm thankful to this organizer, Dr. Ashish, Sneha, and NMPI on other team who has given me an opportunity to be with you today with such an august audience. So when Sneha called me up and wanted to tell about which particular topic I should speak, I said, please don't give me a topic like radiation safety and all those things. Give me some other topic. And she made my task simple as well as difficult both. That's simple in the sense because the topic is very good topic she has given, but I don't know what to speak to you. This topic, when we talk about revisit of HR requirement, definitely the technological advancements has been taken place as far as the equipments are concerned or new radiopharmaceutical which is coming to our country. So I felt what to speak to you, what to tell to you, because it's just like between the employer and employee. Say employer doesn't want to employ more employee, and employee wants that when the workload increases because of many reasons, that they want to share, they want that, okay, this particular person should do this work or that work, whatever it is. So it is basically a topic which if I give it to you, and then you start telling about your perspective, your vision, and here I'm standing as a regulator, definitely I'll give the vision which is neutral, which I feel is open for discussion. So the question comes when Sneha wanted to give me this topic, revisit of HR requirement. I said, what is really revisit is required because of the technological advancement in the field of nuclear medicine. So worldwide, if you started comparing international scenario, no doubt about it, we started way back from gamma camera. Now we are in PET MR. We started with iodine 131 technetium. We are talking about lutetium, alpha therapy, and all those things. We talk about a simple solvent extraction generator. Now we talk about a radiopharmacy of good number radioisotope, good ligands, good peptides, many things. Really, we need to revisit this particular thing. So I said, yeah, this topic is a debatable issue. And I'm going to give my perspective to you. And what I did it, when I started making this presentation, I was keep on thinking how to make the slides, what to present to you, because you people are expert in your subject. And I'm not telling you about the physics or clinical things to you. I'm just giving the, what you can say, the raw data to you. And now we can decide whether really it is required to really go to revisit this particular thing, because everyone has his own perspective, as I'm telling you. Employee, employer, HR department, company's profit and database, many things are there. So before going for that, actually, I should tell you in the next two slides, what is HR, what is HR policy, what is HR objective, and every hospital or organization, the HR is one of the most important things. If your HR department is very strong, definitely your growth increases. And when I was making this topic, I was started consulting with Dr. Anshur here, sitting over here, Dr. Malpani, who are the basically people having good experience in this field. Okay, what to talk? And everyone was telling because their own experiences. Then I said what to conclude, and then I put many things over here, and then we can decide. This particular then talk would be open. This talk is not a invited talk, but a talk which we can debate on this particular talk. So if we talk about human resources, now I'm going to talk, use this word HR. It can be defined as a total knowledge, skills, creative abilities, talents and aptitudes of the workforce in a given organization. No development is possible without proper planning, and HR planning is a prerequisite to human resources development. HR planning in nuclear medicine must provide for the implementation of ongoing activities, meeting the demands of changing technologies and expansion programs, replacing a workforce dwindling as a result of retirement or separation, and deploying staff to take care of any excess or shortage as the case may be. As I'm telling you, don't consider HR is a very small department. HR department is not only to recruit and give the staff to particular department, but many other feathers are attached with HR. If I'm telling you, if HR is strong, HRD is strong, definitely the organization growth is there. So to summarize, the objective of HR planning in nuclear medicine should be to optimize the HR contribution to its growth and development, and to prepare nuclear medicine to meet the inevitable challenge of change. If I continue the previous slide, it is relatively easy to forecast HR needs once the objective of nuclear medicine are clear, provided a reliable database is available showing the breadth and depth of NM practice, the range of nuclear medicine products and services, and the profile of nuclear medicine workforce. It will be possible to extrapolate future needs from this database in terms of the size of the workforce, staff in each category, whether it is physician, physicists, technologists, radiopharmacists, nurses, and other supporting staff, and often the qualification and experience. It is important to note the age structure of the workforce in order to plan for replacement as a result of retirement and separation. Whatever the words I am using, this is not my words. These are words, if you Google it, if you say to IAEA, you can find, and HR is very, very important. And why I'm telling HR is important, myself has done diploma, PG diploma, human resources management as a one thing, so that I should know what are HR. And what I understand HR is the productivity of can increase in the particular, department if the organization thinks about the employee. If you don't think of the employee, don't motivate them, definitely productivity is not going to be there. That is the difference between the government and the public sector. What they think and how they know how to extract the work from an employee. Now I'll come to this slide, which stands for HR objective. The ultimate aim of HR development is to place the right people at the right time in the right position so as to tap the full potential of the workforce for the benefit of the organization and the staff. You see this multi-star hospitals, what they know how their HR department is very strong. And why in the government HR is very, because they don't know how to utilize the people. Human resources development builds a work culture where each of its members is happy and satisfied with the work and life. HRD is not a means to an end, but an end in itself. Development of the individual is the ultimate and single goal of HRD, and there actually we miss. Most of the organization miss this particular line, and the line which I told in my first sentence, to keep or to place the right people at the right time in right position, and until there is no development, until there is no motivation, HR fails. And that is why I think development of the individual is the ultimate and single goal of HRD, working on the principle that if an organization takes care of its staff, then the staff in turn will take care of the organization. It's a very beautiful line actually. When I got my appointment, my boss told me the same thing. If you take care of the organization will take care of you. I don't know how far it is going to be fit, but generally these are the words which tell. But it has been seen, if HR taking care of you, then definitely you take care of it. Why I've told about HR in last two slides is because when we talk about HR, definitely we have to, when to revisit it, many things have to be taken into account. That's what I've told the perspective. When you are working in your department and you feel the workload increases, if you feel the number of modalities are more, definitely demand to the HR department, sir, I need a workforce. But they always think that how with a minimum workforce they can extract the maximum work, because they don't want to unnecessarily spend money on these things. So right people at right time, at right position is what HR talks about. Now, when we talk about whether to revisit nuclear medicine because of technological advancement, definitely we started with gamma, talk about PET MR. We started with technetium. Now we talk about a good number of radioisotope, and it is growing like anything. So do we really require a practice specific person? That what many organizations are doing now. Initially, when I was coming with Dr. Anshu and Dr. Prabhu in the morning, we were talking about there was only one time the radiologist is there. There was no nuclear medicine physician is there. Now we talk about organ specific radiologist. Organ specific, no, there are cardiac people. When you talk about, still in India, when you talk about nuclear medicine, there are people who are good in oncology. There are good people in cardiac. There are people good in neurology. So organ specific things we are talking about. So in such cases, to run a department, do we really need certain kind of thing? Yeah, in a public sector, in an organization like a big hospitals, they can afford. But are a small clinics, they can really afford those kind of things? That we are going to discuss in the further slides. Now, in my view, the requirement depends upon the workload or the modalities in the nuclear medicine facility. What I understand. When you require a good forces, either number of modalities are more in the department. Suppose a clinic is there, because now when we have to talk about a standalone center, we talk about a hospitals. Standalone center is working with a one PET CT or one SPECT CT, but a big hospital is having a gamma camera also. They're having a PET CT also. They may be having a PET MR also. They are doing low dose therapy also. They are doing high dose therapy also. They are working not only with technicians, they are working with lutetium. They have different kind of pharmacy, radiopharmacy is going on. So what I feel we have to really look into it. If at all the number of modalities are more, it is increasing in the particular setup, or the workload is increasing. Suppose in a one modality only, we have a lot of workload and we cannot really share that particular thing that we really need a staff. So in my thinking, when I was making this presentation, I thought, yeah, generally when we were to look into it, revisit, definitely we require a workforce when a number of modalities are more, or the workload is increasing. Then it is requiring more. Or suppose when we talk about a center which works not only the way do the research work on drugs, definitely require different kind of workforce that I'm going to cover in the next slides. Now, if you see what is the growth taking place, so I'm having a data of 10 years, but I'm presenting it over for 6 years. In 2013, when I see it was 100 centers are there. Now we are approaching towards 400 centers, nuclear medicine facilities, which are licensed for operation. So in last 6 years, if you see, it started with 240, now we are 391. It may grow up to, is it 2021 data of December, but if you see in 2022, what so see the growth which started now where we are. Started in 2013 with 100, now we are around 400 centers. So see the growth of nuclear medicine. Now when we talk about out of this, there are 391 which I am telling you. So when we think about okay, what is standalone center, how many standalone centers are there which are in the taking care of PET CT and all those PET CT like small setups are there. 170 are there. It means about 220 or 230 are in the hospital premises, and there are small medical imaging service we are talking about. There are 170 are there. So this is the growth, and when we see out of these 391 or 400, 262 hospitals are there which are practicing with beta therapy. High dose therapy, there are 143 centers are in the country. Low dose therapy, 278 hospitals are working. Similarly, there are certain non-imaging techniques they do. PET CT, there are 320 PET CT in the country, 4 PET MR, 202 SPECT, and 90 SPECT CT, and 21 medical cyclotron. So this is a database. Database is required for the HR department also, and this database we also have it because finally you have to come and take the permission from regulatory authority. Regulatory authority is having database. So I am trying to find out whether we really require a workforce, and if at all workforce is required, are the workforce available, or if the workforce is available, if it is become mandatory, everyone able to fulfill this requirement or not, then only we should work. So this is the place. If you see the growth, now we are talking about 320 PET CT licensed, 4 PET MR, and see SPECT CT 90 and SPECT 202. This is the workforce, and 140 high dose therapy. Now, if you really think with a hospital where there is a gamma camera also, there is a PET CT also, there they do high dose therapy also, and the requirement says you should have a one nuclear medicine technologist or physicist. Then the question comes when the inspection takes place, they feel, sir, we are overloaded. I have to look after the high dose therapy of that particular, which is other premises. They have to take care of this also. Though the requirement has been met, because this requirement has been given by regulatory authority, but are the employer is giving the justification, or they are justified that okay, this work what they are doing is okay, or they have to motivate and all. So now we have to balance it. Okay, where we really require it or we don't require it, and if we require it, workforce is there or not there. Do the demand we can able to meet the supply or not? So that we can able to analyze this data actually. Now we see how many technologist courses are going on in the country. There are 22 are there, 3 have been stopped. 19 such courses have been recognized by regulatory authority. And if you see the DM or MD and DNB seat, about 60-65 doctors are going to be available in the country every year. So now 110 such nuclear medicine technologies of physicists are there. It means what is the work strength coming out? About 60 to 65 physicians, 100 to 110, 120 technologists. This is the workforce. I have already shown the growth, how many centers are adding every year. And as on today, there are about 757 doctors are there, 1253 registered nuclear medicine professional technologists are there. Now see, what is the scenario right now in the country? About 400 nuclear medicine centers, about 1250 nuclear medicine technologists or physicists, and about 750 doctors. So do you think that we really look into it, whether the workforce or to revisit it, what type of thing has to be done? New courses are coming up. Many people are there in the market, but are we able to fulfill the demand? Are we able to demand what is there being supplied or not? So as on now, what I consider, sorry, we'll conclude it before that. These are the different kind of procedures going on that I'm thankful, Dr. Anshu, that I've just wanted to know, okay, what are different PET scans are to be carried out most commonly. He told me there are about 5 or 6 which are commonly done. Maybe some specific may be done in some other center. Maybe as a whole body FDG brain scan, cardiac PET, Dopa brain scan, or gallium dotatate, or gallium PSMA. These are different kind of PET scan is done. And similar, there are list of 26 nuclear medicine scans which is given to me. I have taken out 17 out of which is more common. So I'm just telling you, just try to compare what staff is there, how many facilities have come up, and what type of scans we are doing it. And what is the new radiopharmaceutical which is coming up? Do we really require, suppose my center is a standalone center, I am only doing technician or I am only doing FDG. Do we really require a specific kind of person to take care of it? Or it is required in a big center, big hospital where they do a lot of research work and new medical cyclotron also there, and they are basically doing a lot of radiopharmacy work. Or whether it is a teaching institute. Because demand is going to be different in different places. If it is a teaching institute, demand of manpower is different. If it is an institute where drug research is going on, it is going to be different. If at all it is having a medical cyclotron, it's going to be different. If it's a standalone center which only talks about spec CT, I cannot say you should have this. So only thing, whether to revisit it, what to go about it, it's again a topic of debate. We cannot say it is required. Similarly, we talk about therapeutic nuclear medicine, high dose, low dose, lutetium, PRRT, PSMA, radionuclide therapy, samarium, cyanovectomy, and all those things. Then that of procedure of TheraSphere, SurSphere, microsphere, what do we call about? So these are the procedures. Now, what is the work we are doing? I'm talking about the fraternity where where this particular talk I am giving it. Nuclear medicine physicist, or sometimes it is called nuclear medicine technologist or medical physicist in nuclear medicine department. What I gather, what I know, I have written is usually they are involved in this kind of work: preparation of radiopharmaceuticals, acquisition and processing of clinical images, delivery of therapy treatment, quality control of nuclear medicine equipment, radiation survey they carry out, radioactive waste management they take care of. They take care of maintaining of logbooks, they maintaining of dose record, radiation work. Now, if you see this particular work, the work of not only the technology is involved, the work of physics is involved, the work of dosimetry is involved, the work of radiation safety officer is involved. Now, if a small center is there, which takes care of only one kind of technician, are we really have to segregate this particular work in different workforce? Or if at all it has become mandatory, are we in a position to fulfill this requirement? Because many countries, if you see the international scenario, it is being done. If you compare India with US, Canada, UK, Australia, Oman, anything. See, if you see the IAEA regulations, they talk about something, but are we in a position to fulfill that or to comply that or not? If you see in India, a physician technologist is there, and technologist is basically doing the work of physicist also. They are doing the work of radiation safety officer also. They are doing the work of radiopharmacy also. But if you go to US and all those things, or if you go to UK, they have a requirement of radiopharmacist. Nurse, they have a requirement. We don't have. We just used to post a nurse over there, but nurses are not qualified over there. We have to make them training over there. So international scenario, are we in a position to just copy the international scenario put in India? And when we talk about, are we in a position to take a standalone center in our mind and then start comparing with a big hospital like AIIMS, SGPGI, PGI Chandigarh, or Kokilaben or JhaSchools? A lot of good work is there. A lot of work is being carried out. So here we have to really think about it. So what I feel is, presently, if you see the staff requirement, there is no doubt because new courses that keep coming up. Every month or every 2 months, new course comes up. And we are just fulfilling the requirement. Okay, this particular institute is producing MSc nuclear medicine technology also, BSc nuclear technology also, PG diploma. The workforce is keep coming up. But are we in a position to absorb that qualified workforce? However, the requirement may arise. I consider that in certain cases, if at all our department is involved in few of the other practices, definitely workforce is required. First, I feel is, let us suppose when an individual prefers to work, why the problem is coming up? Because it is not in the practice of nuclear medicine. It is being happening in radiotherapy. It is happening in many other things. When you come out from an institute like RMC, or when you come out like institute like AIMS, where you have been taught on PET CT also, you have been taught on medical cyclotron also, definitely you would prefer to work in a center which having all the modalities, because you want to grow. It is not your fault. But are we in a position to fulfill your requirement? Then what exactly happens if you go to the area where only SPECT is there, gamma camera is there, the student doesn't want to go. They said, sir, I would prefer to go at a place where this all modalities are there, or they wanted to work in a place at one particular location. They always wanted, I have come out from Bombay, so I would like to take a job in Maharashtra region because of certain preferences. So because of that, the workforce requirement starts in the center, rural areas and all those things, or at a place where only a SPECT is there. And definitely a place where a small standalone center is there, which is only SPECT, who is doing only technician, only doing 4 or 5 scans in a day. They cannot afford and they cannot pay to you. And definitely you don't want to stay there. Then the requirement comes in that particular basis. If it has been seen, there are certain hospitals and clinics which we have seen it, they used to keep the standby person with them. They don't just comply the requirement to keeping a one nuclear technologist. They always keep 2 people. So that if one goes on leave, they are not complying the requirement, they are working on the quality also. They don't work, okay, I am a trained person, is ले लिया, कोई radiographer को ले लिया तो काम करा रहे. ऐसा नहीं करते वो. They used to keep 2 people. One is required, other they are keeping it in case of, suppose someone goes on leave, at least alternative arrangement is there. Similarly, what I have seen it, when the application comes to us for new courses, they see only we have one technologist, one physicist, and they have list of other doctors and all those things. And when we say they want to start a MSc nuclear medicine technology or BSc, then with 10 people or 5 people, then the question arises, are these people who are basically doing the routine job, are they in a position to take up the classes and do the justice with the students and doing teaching stuff? So there actually debate comes. Institute wants to start because they want to enroll candidates, they want to earn money, or they are looking for the future of the growth. But are the staff who is there in that particular facility, whether they can do the justice with the patient throughout the day, taking a scan, or they do justice with taking practicals and theory classes for the students? Definitely in such places, staff requirement increases. Yes. In case of large institution where research work is going on, there are places where they do research work apart from the routine work. So they ask for clinical research officer. They will definitely research. They require radio pharmacists. They require special technology who know the pharmacy and all those. Or in case of PET CT, SPECT CT, PET MR, institutes wants to keep a dedicated radiologist. So generally it so happens, no, but now the practice is going on slowly. In bigger hospitals, they take the help, but nowadays nuclear medicine physicians are good enough. They know about it. They know the radiology. They can take care of it. So these are the scenarios where the staff requirement may take place, or additional staff may take place. So the important question which needs to be addressed is that if a national regulatory authority like AERB puts the staff requirement as a qualification, no, your department should have a separate radiopharmacist also, or a standalone center, or a hospital which does not have a workload, whether they can able to comply it or not. When we know a nuclear medicine technologist knows radiopharmacy, are we in a position to take a specific radiopharmacist? It is required because new radiopharmaceuticals are coming up. But if the drug research is not going on, new radiopharmaceutical is not known. If a regulatory authority says, because when they talk about in general for all the hospitals standalone. They cannot say these hospitals, they have not categorized the staffs and all. hospitals and all. So this is one of the important requirements. If at all they tell whether we can able to fulfill or not, and I have already told a database to you, how many hospitals are there, how many physicians are coming, how many technologists, physicists are there. Do we really require a specific person? If specific person is required, where it is required? If we want to really revisit the nuclear medicine, and if you want to compare the international scenario, what is going on abroad. So in conclusion, I would like to say at the country level, the development of HR for nuclear medicine involves partnership with the governments, maybe it Ministries of Health and Education at the center, at the regional health, professional bodies like Society of Nuclear Medicine and their branches and Association of Nuclear Medicine Physicists, and academic bodies like National Board, College of Nuclear Medicine, and sincerity of purposes, commitment to the cause, and close cooperation and collaboration among partners are essential for effective HRD in nuclear medicine. So what I want to tell you, if this topic, it is very difficult to say, yes, we have to really look into it as far as staff requirement is considered because of the technological advancement. And when we talk about how much modalities are there, whether the workload is too much, whether our department is handling all different type of radioisotope, different kind of pharmaceuticals, whether doing the fluorinating, DOPA also, we are doing FDG only, brain scan, everything, talk about carbon 11, 13 or copper and all this. Definitely we require a separate department, a separate radiopharmacist. But if regulatory authority says that if we started taking off, we cannot say it because it may so happen when the requirement comes, a small center cannot able to justify, cannot able to comply. So it is up to the fraternity, it is up to the you people when you think, and up to the employer, whether employer can afford. You people, okay, no, I want dedicated, but there are departments, there are facilities, there are hospitals which have given a thought about it, and they have kept it, and they are growing it. Now it totally depends on quality. Whether you want to look for quality, you require a different kind of stuff, different specialized. But if you want to just run the center, do the scans and finish it, I think nuclear medicine, one person is good enough for taking care of. He takes the duty of RSO also. Doctors comes as a consultant, do the reporting and go back in which the center runs. So this topic is a really debatable topic, and everyone has their own perspective. You may be thinking of your perspective, employer thinks his own perspective, regulatory authority thinks his own perspective, government as a taking an own perspective. So this topic is really a good topic, but if we can debate, we can come to the conclusion. But finally, the choice is yours. With this, thank you very much again to fraternity. Thank you.
Exciting and excellent questions. We can take only one or two questions because of lack of time. Yeah.
This is not a question. Observation. If I come from a small village where I was child at that time. Hello.
Yes.
So while I was child, at that time we had a doctor in our village. They were 4th class. Okay. So now if I go to my village, then their qualification has increased. Now you can get a doctor who is 10th class, and they are treating. And if I close my eye and make an observation, so I believe at least 70% of suffering in our country is being treated by a person who is not having any basic qualification in any kind of medicine, be it allopathy or Ayurvedic or. But if you see that regulator, the regulator is Medical Council of India, and now we have this NMC, National Medical Commission. So they cannot say that because we do not have adequate amount of doctors, and that's why let's get our this patient treated with 10th class person. So they make a regulation. People are flaunting that rule. It's fine. We do not have qualified person to do that. People are doing that. Even if you go to the road, majority of road on the road in our country, we have maximum that 80 kilometers. Now somewhere it is 100 kilometers. But you will be seeing that majority of people is driving with a higher speed. So There also they have some kind of, this road limit is 60 kilometer. Let others to drive 80 kilometer, we don't care. So that is the kind of regulation, and if regulator is saying that I have made the regulation and it should be followed as I am saying, it's not being followed in India, not anywhere in this world. But the job of regulator to assess the proper requirement and make the regulation and try to make that people of the country or whichever place it is to follow that. So always just hiding behind something that we do not have manpower, that's why we are not making that. So that role of different kind of rules in nuclear medicine has been recognized. And if it is not being recognized by regulator here, then they are doing lots of, they are not doing justice to the either to the profession or to the science or to anything. So I don't think that regulators would hide behind that whether we have. If you do not have manpower, then obviously there will be no people, that no one will come with certain kind of courses to create manpower in this field. First, you should have a regulation, give relaxation to the field, and try to get manpower built in that area. So first and foremost important is a regulator is to identify that particular kind of role in that field, and let others to not to follow sometimes, because if you do not have manpower. Previously, that MSc was taught by BSc was taught by plus 2 people and plus 2 people. Right? And likewise, we created the system. If you in nuclear medicine also now we have a DM course, but very unfortunately that the other side of nuclear medicine is very important, and that part is not being taken care of. Any of the regulators, any kind of regulators. That was my observation.
Thank you very much, Ashish. And I want to conclude what exactly you wanted to say. We had a discussion on this topic yesterday only. Basically, what exactly he wants to say, as far as you see, there is no dearth of staff. But what he wanted to give an example, when a road is there, and we have to make kind of 3 different kind of tracks. One where 60 speed, 100, 120. It totally depends the type of car you are having, the type of road you are having, and you can able to regulate. The only thing is the categorization. Basically, if you start categorization, definitely bigger hospital, if you make a regulations requirement, okay, no radio pharmacist required, because nowadays specialized fields have come up. That's what I started by talk. A radiologist was there, nuclear medicine who was able to treat everything, diagnose everything, but now specific things have come up. Similarly, nuclear medicine technologist or whatever has been taught to radio pharmacy, but now radio pharmacy is being growing because different pharmaceuticals, different compounds are coming, different radioisotopes are coming. Now, in our country also, we have to really think about it and to bifurcate this particular road into such a way so that this traffic is going to be open for all kind of facility. And those who can comply, they can follow the 120 speed. Those who cannot follow, they can follow the path of 60 kilometers, because their vehicle is like that, the road is like that, driver is like that. So that kind of thing is required in our country.
Ultimately, Dr. Pankaj, all depends on money. How
Yes.
much the department can make up, how much income it can generate. If the department can generate more income, it can get more manpower. Department doesn't generate more expenses and all, it will not get anything. So I think high time we are late for the orations. And we should
Thank
hand over
you.
the mic.
Thank you very much. Thanks a lot.
Thank you for the lecture.
Thank you very much. We would now like to move forward to a very special session of this conference, the Ernest Lawrence Oration. For this session, I would like to call upon Mr. Rajnath Jaiswal, President NMPAI, Mr. Anindya Roy, and Mr. Amit Nautiyal. Over to you all, sirs.
Hello, am I audible?
Yes, sir.
My screen is visible, sir?
Yeah, it's
Yes, sir.
visible, sir.
Today we have nomination for Ernest Lawrence Oration. Dr. Shivanand Bhushan, who is a very well-known person in nuclear medicine fraternity, and he has done MSc, DMRIT, and PhD. He is right now working as an associate professor in nuclear medicine, Mahe, Manipal. And he is extensively experienced, more than 35 years in nuclear medicine centers. He is a RSO of nuclear medicine facility since last 21 years. He is also in charge of radioisotope research lab at IGMIS, Patna. He is the IAEC member of MCS Patna, NABH and WS XSL. He is a course coordinator and for PGDNMT program from.
Rainath sir, we are not able to hear you properly. Can you come closer to the mic?
Hello, am I audible now? Hello.
Yes, sir.
Yeah, you are audible, sir.
Yeah, now I'm clearly audible.
Yeah, it's fine.
Yeah. Dr. Shivanand Bhushan has been nominated for Ernest Lawrence Oration, and he is MSc DMRIT PhD. He is right now working as an associate professor in nuclear medicine, Mahe. He is having more than 35 years experience in different nuclear medicine centers. He is in charge of radio isotope research lab at IGIMS Patna. And he's a course coordinator for PG NMT program from 2009 to 2012. He's a boss member of Mahe Manipal for NMT courses. At present, he is working as an associate professor of nuclear medicine at Mahe. Would like to share his few memories of his family, and I would like to welcome Dr. Shivanand Bhushan to present for Lawrence Ernest Oration. Thank you very much. Thank you. Dr. Bhushan. Hello.
Please unmute yourself.
Yeah. Am I visible?
Yeah, you are visible. Now you can share your screen as well.
Okay.
We are unable to see your screen, sir.
Yeah, loading. Just 1 minute. Give me 1 minute. Is it visible?
Yeah, it's visible.
Yeah, visible.
Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara. Guru Sakshat Parbrahma Tasmai Sri Guruvai Namah. Meaning is, Guru stands for the teacher who is the remover of darkness and is the harbinger of enlightenment. Guru is Brahma, who is the Lord of creation, also called generator. Guru is Lord Vishnu, who is called organizer. Guru is the Shiva or the destroyer. Guru is the supreme God or Almighty. Guru leads to a path of light. We bow to that Guru. Thus, as a realized soul, Guru is the embodiment of the ultimate Godhead. Good afternoon, everyone. Thank you very much for the kind introduction. I express my gratitude to NMPI President, Mr. Rajnath Jaiswal, Headquarters Secretary, Mr. Anindya Roy, General Secretary, Mr. Amit Nautiyal, and all executive committee members for nominating me for the prestigious oration instituted and dedicated in memory of Sir Ernest Orlando Lawrence. Today, I feel greatly honored to deliver Ernest Orlando Lawrence oration, who was the Nobel laureate nuclear physicist. Sir Ernest Orlando Lawrence won the prize in nuclear physics in 1939. Lawrence has received the Nobel Prize for the invention and development of the cyclotron and for the results obtained with the regards to artificial radioactive elements. Lawrence's research was centered on the nuclear physics. This great scientist has completed his graduation in physics as well as in chemistry. The application of medical radioisotopes like F-18 and many more, what we are using in nuclear medicine, comes from the current generation of medical cyclotron, which is based on his proof of concept only. Now, when we talk about the nuclear medicine deliverables, no one can forget about the chief architect of Indian nuclear energy program. Dear all, yes, I am talking about the visionary, the most distinguished of all, a prominent Indian engineer turned nuclear physicist. Let Homi Jahangir Bhabha. Homi Jahangir Bhabha established the atomic energy establishment at Trombay, Bombay, which we all know currently as Bhabha Atomic Research Center, popularly known as BARC. The more than 390 nuclear medicine centers, more than 20 medical cyclotrons, which are running presently, are witnessing as evidenced visionary of Homi Bhabha's contribution outcome for the nuclear medicine fraternity. Moving ahead, I would like to present to you all the genesis and the evolution of modern nuclear medicine. The genesis and evolution of nuclear medicine, if we talk about, it's a medical radioisotope applications basically, and it evolves further by the amalgamation between the physician, physicist, and engineers' contributions. The first radioisotope administered as radiotracer in human was by George Havsey, who was the father of our nuclear medicine. Moreover, the first therapeutic procedure was done by the medical doctor Saul Herz. The field evolved further with the medical radiation physics and engineering research. Then we had rectilinear scanner by Benedict Cassin, father of body organ imaging. Then gamma camera, SPECT CT gamma camera. Furthermore, we have PET CT scanner by Michael Phelps, medical cyclotron by Lawrence, and finally PET MR demo by Raylan in 1997. In reality, nuclear medicine has seen now more than 8 decades in clinical applications for serving the humankind worldwide. In India, at beginning, there were only 2 pioneer nuclear medicine centers to serve humankind along with the manpower generations, and they were INMAS, Institute of Nuclear Medicine and Allied Sciences, Delhi, and Radiation Medicine Center, RMC at Mumbai. Now there are more than 15 centers for nuclear medicine human resource generation, but no one specializing of nuclear medicine physics postgraduate among them till now. Now, since we came across the genesis and evolution of nuclear medicine, I would now like to present to you the professional life in my perspectives. Next few minutes, I am sharing before you my experiential learning from the nuclear medicine ongoing professional journey in last 3 decades. The 3 icons who transformed me as a professional. I am talking about Professor Dr. B.K. Das, who was my mentor head at PGI Lucknow, from whom I learned the 4 Ds in my life: dedication, devotion, discipline, and determination. The first D for me is the dedication towards the work. The second D for me is the devotion to the workplace. The third D of the discipline for me is the self-disciplined in work life. And the fourth D for me is the determination to achieve the task and goals. The second icon is the late Mr. P. Ramanathan, my program coordinator of BARC, when I spent time with him during RMC training. The tough man, but very soft-hearted. I learned from him Sada Jivan, Uch Bichar, meaning is simple living, high thinking. The third icon in my professional journey, who always remains in my thoughts, is no one than the teacher, Professor Dr. K. Ram Narayan. I came in contact with him during my first faculty development program at Mahe, Manipal. I learned so many tips and tricks of teaching profession from him. His message of 3H, head, heart and hand to the teaching professionals and learners I never forget. The first H is head, for acquiring the knowledge and becoming a lifelong learner. The second H is hand, for the hard and dedicated performances. The third H is heart, for positive attitude and passionate towards work. My life learning from these all were करत करत अभ्यास के जरमती होत सुजान रसरी आवत जाते सिल पर परत निशान. It means that nothing is impossible since practice makes a man perfect. So dear all, I am really grateful to my professional mentors who made me capable enough that today I am presenting before you all. So now let us see, with the time we all paving towards what called modern nuclear medicine specialty in the current era. Conventional nuclear medicine changing from basics physics, chemistry and biology to advanced molecular science and technology, along with the engineering and medicine. Conventional nuclear medicine practice advancing towards precision and personalized molecular nuclear medicine, nano radiotheranostics, luminescence imaging. So time has come to reimagine ourselves. Moving ahead, we have the broader subfield of the workplace environment. The nuclear medicine professionals' work areas are also gained momentum. These work designated broader areas for the professionals are clinical nuclear medicine technology, nuclear medicine physics, nuclear medicine radiopharmacy, and radiation safety or the radiation protection areas. As per the international standard of classifications of occupations, that's called ISCO 08, that's in the under the major group 2, includes the health profession and others. Medical physicists accepted as a health professionals, and they are the essential component of radiation medicine. So this is by the IAEA Human Series publication of 25 in August 2013, support the harmonization of education and clinical training worldwide, as well as to promote the recognition of medical physics as a profession. Medical physics specialties an essential component of radiation medicine. Subspecialty field classified are medical imaging physics, includes the nuclear medicine physics, radiotherapy physics, and medical health physics. Now, after talking about so much of complexity of the workplace environment and professionals working in silos as a specialty work areas, don't you wonder from where it all started? Okay, so let me present to you all the contribution of the Nobel Prize winning physicists, which were very much relevant to the nuclear medicine deliverables. First, we have Wilhelm Röntgen. In recognition of the extraordinary services he has rendered by the discovery of remarkable rays, subsequently named after him, that is called X-ray, and that was the first medical image creation. In modern molecular nuclear medicine, we use these X-rays as a fusion imaging in SPECT/CT and PET/CT modalities. Next is the Anthony Henry Becquerel for his discovery of spontaneous radioactivity. Next is the furthermore, we have the Marie Curie and Pierre Curie for the discovery of artificial radium and polonium radioisotope. Henry Becquerel, who was the French physicist recognized for radioactivity, shared the Nobel Prize with Marie Curie and Pierre Curie. Another nuclear medicine physicist, James Chadwick, received Nobel Prize for the discovery of the neutron, and Carl David Anderson for the discovery of positron. None other than the Pavel Cherenkov, along with the Elia Frank and Igor White-Tam, received the Nobel Prize in Physics for the discovery and the interpretation of the Cherenkov effect, potential of luminescence imaging. So far, we have talked about the nuclear medicine genesis and evolution, my professional journey and workplace environment. I even told you all about the contributions of the Nobel Prize winning physicists and their contributions. But exactly, who is a medical physicist? What it requires to be one? A medical physicist is a health professional with the specialist education and training in the concepts and techniques of applying physics in medicine and competent to practice independently in one or more subfield specialty of medical physics. That is the imaging physics, therapeutic physics, and nuclear medicine physics. Now we talk specifically about the nuclear medicine physicist, then he is someone who is the part of nuclear medicine team. along with the nuclear medicine physicians and technologists, providing assistance with the physical aspects of any new applications for nuclear medicine, performing acceptance testing and maintaining a quality program of nuclear medicine instrumentation and making any necessary dosimetric calculations. If we compare the medical physicist in therapeutic, they are the expert of the teletherapy and brachytherapy. That means they are the expert of external beam irradiation and the sealed radiation source handling, not the unsealed radiation sources, which the nuclear medicine physics and physicist peoples are handling. Next is the now let us ponder over the question, how is a multidisciplinary professional team constituted? A nuclear medicine multidisciplinary professional team can be constituted by the combining together by nuclear medicine radiopharmacist, by nuclear medicine physician, by nuclear medicine technologist, nuclear medicine physicist, and RSO. Nuclear medicine teamwork and collaborative practice is not new to the nuclear medicine. The need was identified and explored by the Henry Wagner et al. Group, which is published in JNM 1978, stated nuclear medicine teamwork and collaboration is the key success. So that's what the interprofessional collaborative practice in nuclear medicine, it was suggested in 1978. So if we want to grow for our nuclear medicine, I'm exploring the nuclear medicine physicist's role in the IPCP as a team, like new procedures coming as an SIRT, PRRT, trans-arterial radioembolization, radiation emergency response team, radiation emergency medical management response team. These are the area where the nuclear medicine physicists can explore their IPCP work. Excellent examples for the exploring nuclear medicine. These are the same response team and then radiation emergency medical management response team. Now, my dear friends, I would like to tell you all the most important multidisciplinary team characteristics. These are the shared team identity. There should be the autonomy among the team members, role clarity, interdependence of the members, the work integration to enhance the team cohesiveness, the shared responsibility to maintain the team dynamics, goal-oriented team tasks, collaboration and coordination networking, so that learn together to work together. Now we will talk about the interprofessional collaborative practice, the competency domains for the integrative patient-centric health outcomes. Ultimately, we all are working together for the giving the patient satisfaction and their safety part. So role clarification, team functioning, interprofessional conflict resolution, collaborative leadership. These are the main domain, competency domain, which one has to be get developed among the professionals. The goal of interprofessional collaboration is a partnership between a team of health providers and a client in a participatory, collaborative and coordinated approach to shared decision making around the health and the social issues. So this goal has to be get achieved. Collaboration and coordination networking, improved patient outcome, creating a culture of continuous improvement, which is possible in nuclear medicine too. Moving ahead, we have the global scenario of medical physicists in nuclear medicine. First, I present to you the American Association of Physicists in Medicine. It defines qualified medical physicist as an individual who is the competent to practice independently one or more of the subfields of medical physics. Medical nuclear physics is a subfield in medical physics that pertains to the therapeutic and diagnostic applications of radionuclides. Clearly mentioned here, except those used in sealed sources for the therapeutic purposes. The equipment associated with their production, use, measurement, evaluation. The quality of images resulting from their production and use. Medical health physics associated with this subfield. This is the AAPM, and they defined their roles and responsibility by three roles are there: clinical service and consultation, the research and development, and finally the teaching. So also we have the Canadian Organization of Medical Physicists. COMP described the medical physicist who deals with the healthcare professionals with the specialized training in the medical applications of physics. Its work often involves the use of X-rays in diagnosis and therapy. It works in hospital diagnostic imaging departments, cancer treatment facilities, or hospital-based research establishments. Moreover, it works in the universities, government, and industry too. The role and responsibility defined by Canadian Association, that COMP, as a clinical role, clinical consultancy role, radiation safety, research and development, and teaching. They also divide in the 4 areas. Next, coming to the British Nuclear Medicine Society, if we see, it says that physics is a key member of the nuclear medicine team and has a specific responsibilities for the scientific and technical aspect of the services. BNMS described the role and responsibility as of the nuclear medicine physicist as a computer acquisition processing, radionuclide therapy, equipment management, radiation protection advisors, quality assurance, research and development, teaching and training. So these are our Indian scenarios are also almost matching with the British Nuclear Medicine Society almost. Now we shall talk about the organizations. As an international organization for the medical physics, they have decided, the medical physicists, their purpose was, the objective of the International Organization for Medical Physics are to organize the international cooperation in medical physics and allied subjects to contribute to the advancement of medical physics in all its aspects. That was their purpose. And so they defined the role and responsibility of the nuclear medicine physicist should work on the gamma camera systems, positron emission tomography, or PET-CT if they have it's available, dose calibrator, probes and counters, quality control equipment and calibration sources, survey meters and contamination probes, nuclear medicine therapy services and dosimetry software and equipment. Moreover, we have IAEA. International Atomic Energy Agency describes that medical physicists works for the safe, secure, and peaceful uses of nuclear science and technology, contributing to the international peace and security and the United Nations Sustainable Development Goals. They define the roles and responsibility for the medical physicist working in nuclear medicine are the calibration and verification of measurement instruments, installation design, technical specification, acceptance and commissioning of equipment, including the establishment of the criteria for the acceptable performance, radiation safety and protection of the patient, staff and general public, implementation of radiation protection program, safety of the radionuclide treatments, optimization of the physical aspect of diagnostic procedures, quality management of the physical and technical aspect of nuclear medicine, collaboration with other clinical professionals, and finally, the patient internal dosimetry. So the IAEA also had described about the collaboration with the other clinical professionals and the other networkings. If we keep considering all in modern molecular nuclear medicine profession and professionalism, success key mantra is quality, security, and safety. Now I would like to present to you all the potential job domains of nuclear medicine physicist in Indian scenario. Let us explore some of the opportunities for nuclear medicine physicists in the service sectors. Nuclear medicine physicists get the opportunities to serve both diagnostic, therapeutic, either in stand-alone centers or in hospital or institution. It can be the production houses, central radio pharmacy, and the medical device industries. Here are some roles and responsibility in the service sector. In the clinical and industrial settings, the first role is the RSO nuclear medicine. They can look after for the diagnostic, therapeutic, including medical cyclotron, to maintain the safety culture at workplace environment. The next role of nuclear medicine physicist can be as a dosimetrist, having the role of establishment and maintenance of all dosimetric standard techniques and equipments. Opportunities in service industry. Furthermore, the role of quality assurance manager, consultant nuclear medicine physicist is also important. It bears the responsibility of quality control, safety, and maintenance of nuclear medicine equipment. The next role of the administrative leadership as a head of nuclear medicine physics. administrative leadership as a head of nuclear medicine physics unit, which has the responsibility of the administrative control of nuclear medicine physics, supporting the staff's HR management of existing workforce and the planning for the future growth of complying the regulatory requirements. Now, when we consider education and training sector, the role of teaching faculty, trainer, educator in nuclear medicine becomes important because it has the responsibility to provide the teaching, training, and competency building to medical and non-medical graduates, supervising postgraduate and PhD students, train the trainers, take part in faculty development programs, and continuing education, being a lifelong learner. Moving ahead, we have the roles and responsibility in research, innovation, and entrepreneurship sector. Now, when we explore the research, innovation, and entrepreneurship sector, we get another significant role of research scientist to plan, conduct, complete the research work using radioisotopic techniques in preclinical and clinical applications, the phantom studies, the equipment design, development, and innovations in the nuclear medicine field, to conduct drug development and preclinical trials on phantoms and laboratory animal systems, human volunteers, for designing and development of newer radiopharmaceutical for the dosimetric calculation, diagnostic reference levels to calculate. Invention and innovation and the entrepreneurship. Now, the invention, if you see, it is in the object, process, or technique which displays an element of novelty. It is a radical breakthrough in the science or the technology which extends the boundaries of human knowledge. But innovation is the application based. Innovation is the process of making improvements by the introducing something new, the process of translating new ideas into the tangible societal impact. It is the changes to create a new dimension of performances. It is a creative idea that comes into reality. Now we talk about innovation and entrepreneurship. Basic science helps a person to make inventions with the general concepts, whereas clinical medicine and technology helps to achieve more opportunity to the innovation for the application-based research. Now we need to understand the changes and challenges of the nuclear medicine physicist in emerging career pathways. There are the various driving forces that reinforces the changes and challenges to nuclear medicine physicist role, and these are driven by the vendors research and development, fusion imaging technology, and the medical cyclotron developments. It extends the task and responsibility because of the skill mix competencies to develop, changes in the professional needs, changes in the educational programs, changes in the primary professional training and curriculum continuing education, or the CPT curriculum. So these are the driving forces which are reinforcing the changes and making the challenges to us also for the nuclear medicine physicist. Now here are some recent advancements in nuclear medicine physics which are quite interesting to know. We have nuclear nanomedicines and nanotheranostics. We have the silicon photomultiplier in the PET and PET MRI, that is detector developments, radiomics, artificial intelligence, algorithms in nuclear medicine, and furthermore, radioisotope production by the ultra-intense laser. Moving ahead, we shall also have a look of our recent advancements in the nuclear medicine dosimetry. We have quantification, homogeneous distribution of radioactivity in the source organs, biological dosimetry, and finally, the integrated patient-specific dosimetry. Now, recent advancements in the nuclear medicine innovations and entrepreneurship are instrumentation and computational development, automatizations, robotics, and the unmanned aerial vehicles like drones for the radiation safe handling, radiation monitoring, development of the new miniaturized particle accelerator for research and clinical sector, development of the new technologies like integrated microfluidic chips and other automated chemistry and biological screening technology and nanotechnologies, new detector technology for PET and SPECT, development of the new iterative algorithms and high-speed, high-capacity computational systems. In India, new education policy 2020 highlighted the innovations and entrepreneurship culture to be get inculcated from secondary education to the professional higher education. These are the opening the avenues to become a self-reliant, grow economy and make the Naya Bharat, New India. We nuclear medicine physicists also can be a part of the mission. There are also certain opportunities that can be aligned with the Government of India initiatives for the enormous professional outcomes, such as involvement in the digital health mission for the remote sensing and control of nuclear medicine services and the radiation monitoring, techno-entrepreneurship to open more avenues of employment and entrepreneurship, process and product development, develop a strong academia-industria collaborative partnership, startup programs to grow in knowledge and strengthening the Indian economy. Now, how shall we summarize the job of nuclear medicine physicists? Let us see what it requires. It needs, that means summary is the equipment management. We need quality assurance. We need the data acquisition processing works to complete, research and development, innovations for the newer techniques, teaching and training, radiation protection, patient handling skills, management and administration of setting up and the operation of nuclear medicine facility. In addition to these job descriptions, advanced practitioners' role of nuclear medicine physicists need to be explored further. So now we shall talk about the multidisciplinary practice of nuclear medicine, which is the next generation is opening up. The next generation of medical physicists, nuclear medicine should include the metabolomics and radiomics, the image processing and machine learning, internal patient-specific dosimetry, mathematical modeling, and so on. Now, keeping all those in mind, I would like to present the expanding and extending role of nuclear medicine physicists, and these are the analyzing and optimizing clinical outcomes, artificial intelligence with the clinical practice, digital imaging physics, data processing, and telenetworking, radiation therapy collaborative work, SIRT or the PRRT, on-site synthesis of radionuclides and radiopharmaceuticals for diagnostics as well as therapeutics, PET-CT, PET-MR, and cyclotron operational troubleshooting, safety and maintenance of the quality control facilities. Now, we want the nuclear medicine department to expand its influence, then we will have to understand the need for the standardization of this profession. In nuclear medicine education, we need to look upon the uniform course nomenclature, course curriculum design and delivery, the practical training aspects, and the assessment tools and the methods. Now, in nuclear medicine clinical practice, if we must have to inculcate the team culture, develop a professionalism, ethics, and behavior to enhance patient safety, quality, security, and satisfaction. Now we shall discuss the regulatory standards for the education and practice. In India, CNMST has been constituted under the umbrella of NMPI for accreditation, certification, and registrations of nuclear medicine non-clinical professionals in India. Registration will help the government to consider for the professional data register in the pan-India. It ensures registration, verification, accreditation, and licensing of nuclear medicine health professionals as a nuclear medicine technologist, nuclear medicine physicist, nuclear medicine pharmacist, and nuclear medicine radiation protection specialist as an RSO. Now, at last, there are certain future directions. What I would like to share with you all is the physicist can play a tremendous leading role to bring the changes to deliver the nuclear medicine services to last man of India. Nuclear medicine community services, I mean to talk. Nuclear medicine on wheel, that is mobile nuclear medicine services in India. Tagline for this would be reach to unreach nuclear medicine services. This is a great challenge for our nuclear medicine physicists to take a lead role. Reimagination of nuclear medicine manpower planning, considering modern technological advances in nuclear medicine education, practice, and future requirements to comply with quality, safety, and security. Time has come by regulators to revisit, rethink, and reimagine the inclusion of nuclear medicine physicists in ARB Safety Code of India, which is the immediate need of the modern molecular nuclear medicine facilities. I thank everyone present here. So I thank you everyone. I would like to express my special thanks to Dr. Arunji Maya, Dean MCHP, Dean Committees and Mahe Management. Dr. Sumit Suresh Malapure, our nuclear medicine physician at KMC Manipal, my all department colleagues, UG, PG and MT students, research scholars at MCHP Manipal, parents and family members, NMPI colleagues, friends and all well-wishers. thanks to the 6 NMPI Con organizers provided me the opportunity to present here. Special gratitude to the parents, family, friends, relatives, and all well-wishers whom I have not quoted or missed by name unintentionally. Indebted to visionary Dr. TMA Pai, who is the constant source of inspiration in my ongoing professional journey. So with the quote, I can stop my talk that the progress is never permanent, will always be threatened, must be redoubled, restated, and reimagined if it is to survive. With this quote, I am stopping here. Thank you for the patience listening to me. Thank you, one and all. Thank you very much.
Thank you, sir. And I really appreciate your excellent oration lecture about the need for an physicist. And I am glad that I was your student. And it's my pleasure and honor to be here and bestow this oration to you along with other NMPI officials. Many congratulations, sir.
Thank you.
And here,
The sound is not there from this part.
Congratulations, Dr. Bhushan.
thank you, sir. And we will deliver your plaque and oration certificate to your registered address.
Thank you.
Thank you, sir, and many congratulations. Grace, it's over to you.
Thank you, sir. We will now disperse for the lunch break and we shall assemble back as soon as possible for the remaining sessions. Thank you.
मीट में शेयर करो करना
हाँ, हाँ, ठीक है।
उसका
e-LoRa powerful platform for regulatory process.
Welcome back, everyone. We now move forward with the continuation of the second session. Ladies and gentlemen, please stay attentive for the upcoming noteworthy lectures. The first speaker now would be Mr. Prathamesh Rajai. I would request the chairpersons to kindly introduce the speaker.
Dear brothers and sisters, welcome to hear a very interesting and important lecture by Dr. Prathamesh Rajai. He is from Vidya Hospital, Mumbai. He will be talking about e-LoRa, a powerful platform for regulatory progress in India. e-LoRa has always been very inquisitively interesting for us. And tomorrow is going to be the law of the land. So everybody will be registered with e-LoRa. And let us learn more about it from Dr. Prathamesh Rajai. Over to Dr. Prathamesh.
Thank you, Chairperson, for the warm introduction. To the respected Chairperson, my teachers, colleagues and friends, good afternoon to everyone. And many thanks for the organizing committee for giving me an opportunity to deliver a talk. I'm going to talk on the e-LoRa, a powerful platform for the regulatory processes in India. So as we all know, in last 2 decades, we have seen the accelerated growth in the application of ionizing radiation technologies in the field of medicine, industry, and the basic research in India. So because of this tremendous growth, has posed a tremendous challenge to the ARB for the regulating all these facilities to ensure the safety and security of the radiation facilities effectively and efficiently with the limited resources available with the ARB. To meet these challenges, in year 2014, the ARB initiated a state-of-art e-governance system, which is popularly known as e-LoRa, e-licensing of radiation application. So e-LoRa is a web-based information and communication technology application, establishing a direct communication channel between the ARB and its stakeholders. The exchange of information and communication transaction for the delivering its regulatory services, as well as for the achieving higher efficiency, reliability, and transparency in dealing. The component e-LoRa has chosen in such a way that it will achieve the business solution with the security, performance, availability, scalability, manageability, and the maintainability. The visualization technology help in achieving the cost effectiveness at the investment level and the further during the operation at the data center. These talks mainly focus on disposal of the decayed disused radioactive sources, communication to the ARB in case of death of patient post-therapy, and the communication to the ARB in case of overexposure or the excess exposure. Disposal of the decayed disused radioactive resources. As we all know, the choice of gamma camera system and the PET-CT system are based on the departmental needs, its specification, which the manufacturer defines as the camera performance characteristics. The quality control plays a vital role in the assessing the performance of the system, and due to its unique characteristics, few radioactive sources such as cobalt-57, cesium-137, germanium-68, etc. are used. The best practice when we receive any radioactive sources, to secure all the document received during the receipt of the radioactive sources in safe custody. This documented part is divided into 2 parts. The document required to get export license from the ARB and the document required to the airport authority. So to get the export license from the ARB, the detail of the source to be disposed need to be uploaded in e-LoRa. Transporting the details of the source, whenever it is required, the blueprint diagram of the source, the copy of the valid license, authorization, permission of the import, procurement handling issued by the ARB or the BRC during the procurement of the source, attach the copy of procurement certificate license for the operation of the source proposed to the dispose, and the copy of the valid license, authorization, permission for the import, procurement handling issued by the suppliers or the written authorization letter from the suppliers. So there are transport and disposal forms in ELORA. When we log into ELORA system, in regulatory form, there are 3 forms are available in the transport submenu. Number 1, the transfer of the register sources, the transfer of the unregistered sources, and the intimation of the export or transport or the disposal. So the transport of the registered sources in the regulatory form in transport tab, go to the transport of the registered sources and then fill the relevant data. These are the steps. So in the general details tab, the source identification name, number, the name of the radioactive source, activity as on date, the physical forms, all the relevant data need to be filled. Choose the appropriate source from the tab. And the in the general tab, after choosing the appropriate source, then submit the application form. For the separate application forms, for the separate application form to be submitted for the each transport packages. In the package details tab, the information regarding the package in which source are to be transport is to be provided. So the type of package, the gross weight of the package, the volume of the source, the radiation levels at the surface and at the 1 meter external distance, the united numbers, all the details need to be mentioned. In the attached details forms, the respective details need to be uploaded. So after successful submission, the following will be appear. This is the blueprint of this sketch diagram of the source containing and this position of the source. The transport of the unregistered source. So in the general detail tabs, so in that the application for the export of the radioactive source, the transfer of the radioactive source for the disposal in India, the transport of the radioactive source within India, and transfer of the radioactive source to the India supplier. Select the appropriate the tab from the respective tab. Fill the in the general details like the name of the radioactive source, the activity as on date, the suppliers, the details need to be filled. You can download the transport package information sheet from the general tab. This is the sample copy of the transport package details, where the type of supplier, where the supplier's details, detail of the package, maximum radiation levels and other details are mentioned. This is the written authorization which we will receive from the suppliers. So these all documents need to be uploaded in ELORA while applying for the license to export these sources. So they provide the correct information and the document to the ARB to provide the permission letter or the export license for the radioactive material. Any mismatch may delay the process. These are the documents required at the airport authority, like the consignor declaration, delivery challan, emergency responses document, the packaging of the boxes as per the suppliers, original export license issued by the ARB or BRC, and the nominal source data sheet. So these are the sample copy of the consignor declaration, the sample copy of the delivery challan. This is the sample copy of the emergency response document, where the details of the source will be mentioned, and the contact details of the person in the emergency case. This is the export license from the ARB, and this is the normal source data set which is received during the procurement of the source. And this is the TREM card which is need to be given to the driver of the driver of the vehicle. So in the contact details, the all the respective numbers of the person will be mentioned. This is a pics of the packaging of the boxes as per the supply specification. And the best practice to keep all the boxes which are received during the receipt of the source in safe custody in a good condition. This is the confirmation letter of the receipt from the supplier. When we do the application for the intimation of the export, transport of the disposal, we need to upload this letter. And this is the disposal confirmation message in the ELORA. Moving to the next topic, like the communication to the ARB in case of the death of the patient post radioactivity administration. It is most important that you have to inform the ARB immediately or within 24 hours and the incident. In case of the CPR or RRT procedure provided, procedure, provide the pocket dosimetry to the personnel involved in the procedure, request them to manage the process in a small group or in a rotation or a replacement by keeping the radiation levels in mind. Note down the exposure received during the procedure and check the contamination level of the instrument used in the procedure, and if required, follow the decontamination procedure. The waste generated during this process is discarded as per the safety as per the regulatory bodies. The PVC wrapping on the cadaver should be done at the hospital. Document the exposure rate at surface and at 1 meter. So this is the peaks of the PVC wrapping on the cadaver. Prior release of the patient body to be relative, as per the regulatory body guidelines, should be kept in the mortuary cabinet at the extreme corner, and the radiation symbol and the patient identification details must be placed on the door. In this case, also document the exposure rate at the surface at 1 meter and at the entrance of the room. Mention all the pictures and the related documents in the preliminary report. These are the instructions for the handling the human cadaver containing the iodine-130 radioactive material. The undertaking should be taken by the RSO and the nuclear medicine physician of the hospital from the relative of the deceased with respect to the adherence to the instruction given by the RSO to be followed during the transport and the further handling of the dead body till burial. The body should be transported via road in an exclusive vehicle, and the body should be placed in such a way that the head position further away from the driver and the relative. The relative traveling with the body should not be seated next to the driver or on the body done at the hospital, not remove at any point of time, and the body should be along with the